Hello. My title is a comparative study to evaluate the post-operative efficacy of spinal block versus thoracic breast cancer is the most common surgery associated with significant acute and chronic pain. Thoracic paravertebral block is the gold standard for multimodal anesthesia, but however associated with some minor and major complications. Recently, electrospinal
यूं किया तो म्यूट हो है ना
My title is a comparative study to evaluate the post-operative analgesic efficacy of erectospinal plain block versus thoracic paravertebral block in patients following modified radical mastectomy. Co-authors are Dr. Nitin Hayaran and Dr. S.K. Sinha. Breast cancer is the most common female cancer worldwide. The most common breast surgeries is modified radical mastectomy, which is associated with significant acute and chronic pain. Thoracic paravertebral block is the gold standard for multimodal analgesia, but however associated with some minor and major complications. Recently, erectospinal plain block was proposed by Ferrara et al. In 2016. There have been limited literature on comparison of efficacy of postoperative analgesia between both the blocks, and no studies have been done so far on interpolation with the placement of continuous post-operative infusion catheter. Comparative study was done on 60 adult female patients posted for elective MRM under GA. Clearance was from Institutional Ethical Committee. Aim was to compare post-operative analgesia in patients who received both the blocks at 24 hours. All patients were explained NRS preoperatively. Patients were randomized and allocated to either group E or group B. GA was induced as per standard protocol following placement of either blocks with 20 ml of 0.5% bupivacaine, and a catheter was inserted under ultrasound guidance. At the end of surgery, a continuous infusion pump of 0.125% bupivacaine at the rate of 8 ml per hour was started and continued for 24 hours. During immediate post-operative period, patients were asked whether they have complaints of pain or not. If yes, the site of pain at which the quadrant was asked, and the pain was quantified by NRS as 0, 4, 8, 12, and 24 hours. Injection tramadol was given. If NRS was more than or equal to 4 and total number of doses was calculated, local site was inspected for signs of complications and catheter was removed at the end of 24 hours postoperatively. All data were entered and performed for each patient. Was compiled and tabulated, and a p-value of less than 0.05 was assumed statistically significant. The following table and figure shows the distribution of study group based on NRS score at various intervals. The mean NRS score was comparable between both the groups ESPB and TPVB at throughout the 24 hours postoperative intervals. At the 8 and 12-hour interval, the mean NRS score was significantly lower than in SPV. The mean NRS score was significantly lower compared to TPV groups, but however, they were clinically comparable. And coming to the figure, at 0 interval, the mean NRS score was minimum and increases and reaches at peak at 4 hours and then started to decline till the end of 24 hours. And figure 2 shows the distribution of study group based on the site of pain. The difference in the site of pain according to quadrants of breast is statistically insignificant. And figure 3 shows the distribution of study groups based on mean of consumption of analgesic tramadol. And the difference in the consumption of analgesic tramadol were comparable in both the groups, and no complications were reported in both the groups. And coming to conclusions, both ESPB and TPVB are effective in managing acute postoperative pain after MRM. They are equally efficacious, and site of breakthrough pain in both the groups shows that ESPB may be more effective in managing axillary pain because of extensive spread of LA. Both are equally effective in reducing opioid consumption. Continuous catheter techniques further reduce opioid consumption, and as ESPB is less invasive than TPVB, it may be considered as the analgesic method of choice after MRM. These are my references.
Good morning. My case e-paper title is Comparison of CPAP pre-oxygenation versus conventional pre-oxygenation on duration of safe apnea time in patient undergoing elective surgery under general anesthesia. Introduction. Maintaining tissue oxygenation is of utmost importance in airway management during general anesthesia. Prolonging the safe apnea time reduces the risk of hypoxic injury in case of an inadvertent delay in intubation. The application of continuous positive airway pressure during pre-oxygenation prevents atelectasis despite the use of 100% oxygen therapy, increasing oxygenation and duration of safe apnea time. Come to the aims and objective of our study is to compare the duration of safe apnea time in patient pre-oxygenated with CPAP and patient pre-oxygenated conventionally posted for elective surgery under general anesthesia. Material and methods are: after obtaining approval from the Additional Review Board and National Ethics Committee, we recruited a total of 60 adult patients of age between 18 to 40 years of either sex of our study. The patients were randomized into two groups of 30 patients each using closed envelope technique, group Z, zero and expiratory pressure group, and PEEP group. All monitoring will be done continually. Patient Jeep group will be pre-oxygenated conventionally with 100% oxygen for 5 minutes at the rate of 8 liters per minute. Patient in PEEP group will be given CPAP of 5 cm of H2 during pre-oxygenation using Drager Primus anesthesia workstation. These are inclusion and exclusion criteria of our study. Observation and result are: duration of safe apnea will be measured in seconds from the time of administration of succinylcholine hydrochloride to the time when SpO2 reaches 94%, or a duration of 8 minutes has elapsed, whichever is earlier. Both group members were equally comparable in age group and sex distribution. Mean value of pulse, systolic blood pressure, diastolic blood pressure, and mean arterial pressure between two groups were statistically insignificant at various intervals between PEEP and Jeep group. These graphs showing the comparison of duration of apnea between two groups. The mean and standard deviation of safe duration of apnea was found to be significantly longer in PEEP group compared to Jeep. Discussion. Anesthesia induction usually leads to apnea. During apnea, oxygenation depend on the oxygen reserve stored within the body, which are mainly localized in lungs, RBC, plasma, and myoglobin. While breathing room air, these stores are quantitatively low. The normal store of oxygen in healthy young adult breathing air are approximately 1500 ml, and this may be increased to 3700 ml following pre-oxygenation with 100% oxygen. In summary, our study showed that application of continuous positive airway pressure of 5 cm H2 during 5 minutes of pre-oxygenation with 100% oxygen significantly increases the duration of safe apnea time. This technique can be helpful in increasing the margin of safety in patients with anticipated difficult airway and in case where rapid sequence induction is desirable. Now, our studies conclude that the application of continuous positive airway pressure during pre-oxygenation is simple, well-tolerated technique that may have advantage in patients with anticipated difficult airway, morbidly obese patients with increased risk of desaturation, and during rapid sequence induction where assisted ventilation. These are references of our studies. Thank you.
Judges may ask questions.
I'm Dr. Ituraj. I'm presenting e-paper on the topic Confirmation of Caudal Epidural Space by Epidural Pressure Waveform Analysis. My moderator are Dr. A.K. Sethi and Dr. Rasmi Salhotra. Caudal epidural anesthesia has been used for many years as surgical anesthesia and post-operative analgesia. And there are various reports suggesting that pulsatile waveform can be used as a sensitive method to confirm epidural space in thoracic and lumbar region. And since caudal epidural space is a continuation of cervical, thoracic, and lumbar epidural space, we hypothesized that epidural pressure waveform analysis can be used for identification of caudal epidural space as well. We included consenting adult patient of either sex belonging to ASA 1 or 2 with a body weight of 45 to 70 kg, scheduled for surgical procedure involving inguinal, genitourinary, perineal, rectal, or lower extremities. We excluded non-consenting patient or patient having a skin infection at the site of caudal infection, history of a spinal fracture or surgical intervention, coagulopathies, hypersensitivity, or any other contraindication to epidural anesthesia. In methodology, under all aseptic precautions, caudal epidural space was identified by conventional anatomical landmark method and entered using wetting gauge 2 needle. Such test was performed by injecting 5 ml of normal saline through 2 needle, which also served as the initial priming volume. After a priming volume of 5 ml saline, liquids of lignocaine with ADR were injected as 3 ml, 2.5 ml, 2.5 ml, and 2.5 ml, making total bolus of 15.5 ml. This is the pressure transducer assembly which we use during our cases. And after each liquid of epidural injection, transducer assembly was attached and waveform was looked for and classified as strong, moderate, weak, depending upon its amplitude. After the epidural catheter was inserted and sensory level were recorded. This figure shows caudal epidural waveform as a strong, moderate, weak, or absent depending upon the amplitude of the waveform. In our results, we found that 60% of patients showed a positive caudal epidural pressure waveform after a priming volume of 5 ml. And then after the first liquid of 3 ml lignocaine ADR, 2 additional patients show a positive waveform, making it to a 65% patient showing a positive caudal epidural pressure waveform. Then with the next 2.5 ml of bolus, 1 more patient showed a positive waveform, making total 67.5% patient showing a positive waveform. However, in 32.5% patient, we could not obtain a positive waveform. A strong waveform was seen in 14.8% of patients. This table shows the effect of priming volume on epidural pressure waveform. This is a priming volume 1 of 5 ml, then priming volume 2, 3, 4, 5 of 10, 13, and 15.5 ml. And corresponding a positive epidural waveform was seen in 24 patients at 5 ml of priming volume, then 26 patients showed at 8 ml of priming volume, and 27 patients showed at 10 ml of priming volume. However, 13 patients didn't obtain a positive epidural waveform even after 15 ml of priming volume. So we concluded that epidural waveform can be demonstrated from the caudal space through 2 needle. It can also be used as an adjunct to the conventional anatomical landmark technique for localization and confirmation of caudal epidural space. These are my references. Thank you.
My topic is comparative study between unilateral spinal anesthesia versus ultrasound combined femorosciatic nerve block for lower limb surgery. Introduction. Regional anesthesia techniques are used as an alternative to general anesthesia because both peripheral nerve blocks and spinal anesthesia provide sufficient anesthesia better post-operative analgesia, and higher patient satisfaction than general anesthesia, in addition to being minimally invasive using less resources, and it reduced the pulmonary aspiration of gastric content, which is one of the most feared complications of general anesthesia. The advantage of unilateral spinal anesthesia over bilateral spinal anesthesia are low cardiovascular side effects, strong blockade during surgery using low dose, and the disadvantage is that it requires protecting the lateral position for a while. With the presence of these factors, alternative anesthetic techniques are needed, such as femoral sciatic nerve block. Ultrasound guided may improve the puncture to onset interval and the quality of sensory block in all nerves. While avoiding complication, less local anesthetic is required because it is applied more accurately with ultrasound guidance. Aims and objective. The aim of the study is to compare unilateral spinal anesthesia versus femoral sciatic nerve block by ultrasound guided as anesthetic technique for case undergoing elective lower limb surgery. Material and method. This prospective randomized study was carried out on 60 adult educated patients aged between 18 to 60 of both sex with physical status ASA grade 1 and 2, scheduled for lower limb surgery at Muzaffarnagar Medical College after approval from Institute Ethics Committee and informed consent from each patient. Exclusion criteria. Patient refused, uncooperative patient, unconscious patient, cases with head trauma, history of relevant drug, allergy to local anesthetic, local infection at the site of block, patient with coagulopathy and impaired platelet function, patient with hemodynamics, with previous neurological deficit in lower limb, and previous femoral artery grafts or injuries. Patient allocation. This study includes 60 patients. They were randomly classified with computer by using closed envelope into equal group. Each group contained 30 patients. Group 1 unilateral spinal anesthesia group and group 2 ultrasound guided femoral sciatic nerve block group. Ultrasound guided 822 gauge spinal needle was introduced after confirmation of correct placement of the spinal needle by free fluid. 2 ml of 0.5% hyperbaric bupivacaine was slowly injected over 1 minute without any needle was withdrawn. After withdrawal of the spinal needle, the patient was placed in the lateral degument operating limb for 20 minutes. Then motor, sensory and sympathetic functions were evaluated. Patient group 2, ultrasound guided femoral nerve block. Gel was put on the Doppler curved probe and then the probe put in the sterile sheath. The wideband transducer 5 to 10 megahertz was placed in on the inguinal region to allow visibility of the femoral artery and vein. The nerve was seen in cross section as in hyperechoic speckled triangular over oval shaped structure just lateral to the artery. 22 gauge 150 mm insulated bevel needle. Once positioning was confirmed by imaging, injection of 20 ml of 0.25% bupivacaine and 10 ml of 1% lidocaine was performed in bolus of 5 ml sciatic nerve block. The sciatic nerve was visualized posterior and medial to the lesser trochanter of the femur. Once positioning was confirmed by imaging, injection of 15 ml of 0.25% bupivacaine and 10 ml of 1% lidocaine was performed in bolus of 5 ml after aspiration. Measurement. Demographic data. Onset of sensory block, onset of motor block, duration of motor block, and the first time of needle of rescue analgesia. Result. 80 patients were recruited for the study and 20 patients were excluded. These are the charts. Conclusion, both ultrasound with 2 ml heavy bupivacaine 0.5% given slowly over 1 minute and US guided FS and B using combination of 0.25% bupivacaine and 1% lidocaine resulted in compared adequate intraoperative anesthesia with stable hemodynamic, adequate surgeon with patient satisfaction with minimal side effects, vast score and smaller amount of rescue analgesia. Thank you.
Hello. Hello. Hello.
Hello.
Hello.
Only this time.
Hello.
Good morning, sir.
Yeah, good morning. Good morning, Rahul. Excellent presentation. Right. One or two suggestions and one or two queries from my side. that whenever you are number one suggestions, whenever you are preparing slides, for presentation, avoid using complete sentences, right? Specifically your introductory slide, it was in the form of paragraphs, and it never gives a good catchy impression. That is for your future presentations, right? That is there. Now you have told that you have excluded 20 patients from your study in the beginning, right? That is there. So my query is, at what point in statistical analysis you have excluded them?
Okay, sir. Due to cost was the reason, sir. Cost was the reason, sir.
They were not able to afford those equipments.
Yes, sir. These were not unaffordable people, so would not do that.
Okay, so in the beginning itself, you have excluded them. You have not entertained them in the study itself.
Yes, sir. Same way.
Okay. Thank you.
Welcome, sir. Thank you, sir. Sorry, sir.
Next, please.
Good morning. I'm presenting my e-paper on topic monitored anesthesia care, comparison of the fentanyl propofol and dexmet-propofol in middle ear surgery. Like any other surgical procedure, middle ear surgery are associated with anxiety and pain. The attending anesthesiologist face several challenges in safe conduction of anesthesia. Using monitored anesthesia care in place of standard GA prove advantages in terms of patient cooperation, intraoperatively, avoidance of the nitrous oxide, and early discharge and cost effectiveness. Growing popularity and trend of daycare anesthesia has led to the development of newer and efficient drug regime. Practicing combination of two agents can provide better patient control and allow the use of the smaller dosage of each single agent. We decided to compare fentanyl propofol and dexmet-propofol combination in terms of analgesia, sedation, hemodynamic stability, recovery profile, and any other associated side effect. Aim of the study was to compare the analgesic and sedation efficiency of the fentanyl propofol and dexmet-propofol combination. Objective of study were to check the hemodynamic changes associated with drug, respiratory changes associated with drug, and any other adverse effect associated with the drug. Methods, it was a prospective randomized double-blind study. Source of data was patient coming for the UPM SEPI for the middle ear surgery. Sample size calculation was based on statistical analysis, which includes 60 patients, 30 patients in each group. Group F include the fentanyl group, in which fentanyl 1.5 microgram per kg IV, and in group D, dexmedetomidine given as 1 microgram per kg over 10 minutes as bolus, followed by 0.4 microgram per kg per hour as IV infusion, and propofol was common in both the groups. After institutional ethical committee approval, written and informed consent was taken. 60 patients of either sex, age between 18 and 65 years of ASA grade 1 and 2 undergoing middle ear surgery were included in the study. For the exclusion, allergy to study drug, second or third degree heart block, renal and hepatic insufficiency, uncontrolled diabetes and hypertension, obesity, pregnant and lactating females. And pre-anesthetic checkup was conducted. Patients were explained about the consent technique and were instructed to keep fasting for 68 hours. Lambda number table for the 60% divided in two groups by generated, and to maintain the blinding, anesthesiologist not involved in the study opened the envelope and prepared the appropriate drug-filled syringe according to the code and did not take part in management and observation. Anesthesiologist who administered the study drug was not involved in encoding the data and was also blind to the group assigned. Routine non-invasive monitoring was applied to all patients. IV cannula 18 gauge was secured. Patients were placed supine on the operating table with the head turned opposite, and the oxygen was applied at a rate of 2 liters per minute to all patients. Glycopyrrolate 0.2 mg given to all patients. Intraoperative pain was assessed using a visual analog scale every 10 minutes. A patient complained of the pain during surgery. IV paracetamol 1 gram was planned to give as intraoperative rescue analgesia, and surgeon to give the local anesthetic. Ramsey sedation score was assessed each 10 minutes. Desired sedation level was defined as more than or equal to 3. If less than 3, then rescue sedation with the dose of midazolam. And if RSS was more than 5, then it was planned to convert it to the standard GA. Simultaneously, then operating area was prepared, draped, and local anesthetic infiltration was done by the surgeon using the lignocaine 2% with adrenaline. Heart rate, respiratory rate, mean arterial pressure, SP2 was recorded every 10 minutes till the end of the surgery, then every 15 minutes till while the patient remained in post-anesthesia care unit or the achievement of the modified Eldred score. Adverse event, any associated were recorded. Results include both groups are comparable in terms of age, sex, duration of surgery. Ramsey sedation score was significantly higher in the Dexmed group during the study, as you can see by this table. The time and except at the 10 minutes. And the visual analog score in the study group was comparable during the study, that is both have the same changes in heart rate, mean arterial pressure, respiratory rate and SP2 were also statistically non-significant. The time to achieve modified Alter score of 10 in group D was significantly less as compared to the group F. So conclusion include dexmed propofol combination have better sedation and emergence profile than the fentanyl propofol for MAC for middle ear surgery. Patients were calm and cooperative in both groups, which is desirable for surgery to be done under MAC. Changes in vital sign are almost similar and no group encountered any complication.
Hello. Yeah, thank you. Is the speaker with us? Is the speaker joined for question answer session? Hello. Is the participant available for question answer session? Miss Priya? Hello. Yeah, from tech team.
Sir, session was start 11 a.m. 11 o'clock.
Okay, okay. We can move on to the next one then.
So my topic is effect of intravenous dexmedetomidine, prevention of perioperative shivering, transurethral resection of prostate surgery. It is a randomized prospective study. Shivering is a common complaint patient undergoing TURP under spinal anesthesia. Incidence of shivering during neuraxial block may be reduced by warming the body surface skin. Many drugs have been used like meperidine, clonidine, ketanserin, tramadol, and magnesium sulfate, but none has been completely successful. Opioids have been used to prevent post-operative shivering, but it has some side effects like respiratory depression, low blood pressure, nausea, vomiting, and limited use of opioid after surgery. Dexmedetomidine is a container of clonidine, is a highly selective alpha-2 agonist used as a sedative agent and known to reduce the shivering threshold. Few studies which have explored its anti-shivering potential have inferred that dexmedetomidine is an effective drug without any major adverse effect and provide good hemodynamic stability. The aims and objective bars assess the effect of study on intra and post-operative shivering patient undergoing TBRP with spinal anesthesia. We include the patient of ASC grade 1 and 2 with the age group of 40 to 80 years, male patient, and exclude the patient of known history of sensitivity to study drugs, patient with cardiopulmonary disease, patient with hepatic renal disease, and any patient with contraindication to spinal, patient with severe diabetes, patient receiving vasodilator or medication like to alter the thermoregulation. B. Include the 60 patient of ASC grade 1 and 2 scheduled for transurethral resection of prostate under spinal anesthesia and were divided into two groups with randomly using sealed envelope technique. B. Given the drug in group C 10 ml normal saline intravenously over a period of 10 minutes, and in group D we give the 1 microgram per kg injection dexmedetomidine 10 ml normal saline over 10 minutes. B. All patients were kept in nil orally for 6 hours and intradermal sensitivity tests were done. After securing IV line, a finger lactate solution was given 10 ml per kg body weight. After entering the OT, all vitals were attached and all baseline parameters have been measured. In operating room, temperature was maintained between 22 to 24 degrees centigrade. Vital parameters, heart rate, blood pressure and SP2 were recorded at an interval of every 5 minutes for first 30 minutes and every 15 minutes for rest of surgical time and then 2 hours post-operatively. Subarachnoid block was administered with 0.5% heavy bupivacaine at L3, L4 space with 25 gauge spinal drill under aseptic precaution. After achieving adequate block, study drug was given
Shivering score was assessed by Crossley Mahajan score, and during surgery, shivering score was assessed and recorded at 15-minute interval. If grade was more than 3, prophylaxis was given, which is considered as a failure. Perioperatively, if shivering occurred, if it treated with warm blanket and reassurance till grade 2. From grade 3, 50 milligram IV tramadol was given. Adverse effect, nausea, vomiting, bradycardia, dizziness was noted. Degree of sedation was graded on a 4-point scale. Observation were subjected to tabulation analysis done by using ANOVA test and chi-square test. P-value 0.05 was taken as statistically significant. As we found that demographic profile were comparable in both the groups. Heart rate, as these graphs are shown, that heart rate is comparatively lower in dexmedetomidine group. Systolic blood pressure was comparable lower in the dexmedetomidine group. Diastolic blood pressure was lower in dexmedetomidine group, and shivering score is higher in control group. Degree of sedation was higher in dexmedetomidine group, and the adverse effect is more in control group. In this study, we use injection dexmedetomidine to find out the anti-shivering and hemodynamic effect in patient undergoing transvagal resection of prostate. We found that as compared to control group, systolic blood pressure, diastolic blood pressure, heart rate was basal perioperative was significantly lower in dexmedetomidine, and these findings were comparable with the Ustavi et al. And Karaman S et al. Results of our study shown that none of patient group D had grade 3 shivering as compared with group C. Our study supported by Karaman et al., in which incidence of shivering was higher in control group. Similar study results observed in the study done by Bajwa SSJ et al., Ustabi et al., Prabhakaran K et al., and Ghasani M et al., and Liu ZX et al. Higher incidence of nausea and vomiting was found in control group. This was probably due to the tramadol, which used as a rescue drug for treating shivering in control group. Patients in group D had minimal incidence of nausea and vomiting. These findings supported by the study conducted by Bajwa et. So we have concluded that dexmedetomidine seems to be anti-shivering property in a dose of 1 microgram per kg body weight. Though it produced some sedation, but it did not have any major clinical impact on the overall recovery from anesthesia. These are my references, and thank you. So.
Is the speaker with us?
Stop.
Hello. Good morning, sir.
Yeah, good morning. Good morning, Dr. Shukha. Certainly a well-executed study, right? That is there. My point is that in a dose of, you have used 1 microgram per kg. It was the maintenance dose which you used?
Sir, it is a loading dose, 1 microgram per kg.
And that is okay. That is generally a loading dose. But after loading, just you have given a loading dose. There is no maintenance infusion.
No maintenance.
So generally what happens is, if you want a long-lasting effect or something, the surgery is prolonged or something like that, it's always better, to use a continuous infusion after a bolus to get the maximum benefit.
Okay, sir. I will.
Any other anesthetic agent which you have used to control the shivering?
Sir, anesthetic agent, magnesium sulfate we can use.
Okay.
Sir, clonidine we can use.
Very good. Anything in the past when these drugs were not there?
Tramadol.
Tramadol. Anything before that?
Sir, pethidine.
Yeah, pethidine was an excellent agent being used for the same purpose, right, Dr. Shukha? Thank you so very much.
Yes. Thank you, sir.
Good morning, all of you. My topic is to comparative study on the effect of preemptive doses of gabapentin for postoperative analgesia in patients undergoing surgeries under general anesthesia. Introduction. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Postoperative periods are very crucial for the patient's healthy recovery, and it should be pain and infection free. Postoperative pain, if not treated adequately, it may lead to hypertension, tachycardia, myocardial ischemia, angina, and shallow breathing. And various drugs, they are used for to relieve postoperative pain, like opioids, NSAIDs, NMD antagonists, alpha-2 adrenergic agonists, gabapentin, pregabalin also have been used as preemptive analgesics. Preemptive analgesia is a treatment that is initiated before the surgical procedure in order to reduce sensitization. Gabapentin is a structural analog of GABA. It is primarily an anti-epileptic drug that is used for medication to relieve pain, neuropathic pain. They are used in chronic pain conditions. Then material methods after obtaining approval from the ethics committee, the present study was conducted on 60 patients, ACA group grade 1 and 2 patients, and age group of 18 to 15 years of either sex were included in my study. Exclusion criteria: ACA grade 3 in our patients and known history of allergy or sensitivity to or any other drugs, or patient with psychiatric illness or history of neurological, hepatic and renal diseases like hypertension, peptic ulcer disease. They were all excluded from the study. Then methods, 60 patients were taken. There were two groups. Group G, that is N30, patient who received 600 mg of gabapentin orally 1.5 hours prior to surgery. And group C, 30 patients, patient who received placebo orally 1.5 hours prior to surgery. Then methodology, after overnight fasting, patients were given either placebo or oral gabapentin 600 mg with a sip of water or two 90 minutes before the surgery. Then upon arrival of the patient on the OT, various monitoring devices like NIBP, pulse oximeter, 3-lead ECG were connected, and the basal reading like pulse rate, systolic blood pressure, diastolic blood pressure, respiratory rate were recorded. Patients were pre-medicated with the injection pentazocine 0.5 mg per kg body weight. Then after pre-oxygenation, G was given with injection thiopentine and succinylcholine, and IPP was done with 100% oxygen for 1 minute. Then the laryngoscopy was done with the Macintosh laryngoscope, and the ED tube was fixed. And after checking entry of the both sides, anesthesia was maintained on the oxygen at the side along with the intermittent doses of atracurium and then halothane. And after completion of the surgery, the neuromuscular blockade was reversed with neostigmine and glycopyrrolate. And after adequate reversal was obtained, the patient was shifted to postoperative ward for further monitoring. The pulse rate, blood pressure, respiratory rate, severity of the pain on the mass scale was noted immediate postoperatively, and then at 15 minutes, 30 minutes, and up to 180 minutes. Then as assessment of postoperative pain was assessed using a visual analog score scale, that is 0 to 100, 0 to 10. Then TRE 1 and 2, time at which first request of analgesia was made by the patient, and the time at which second request of analgesia was made by the patient, that is the TRE 2. Injection tramadol 2 mg per kg body weight was IV was given as rescue analgesic whenever the subject requests for analgesia. And then results of observation, both the groups were comparable in respect to age, weight, and duration. Then time of rescue analgesia was observed in my study. Then pain relief was assessed in both the groups by analyzing time of rescue analgesia, that is 1 and 2, that the patient complains of pain for the first and the second time after extubation in the postoperative period. Pain control was better in the group gabapentin as compared to the control group. And our study findings of our study results were in accordance with the Mardani, Kibir, M et al. And Eliman, Mezaz et al. And Sultanzade Zadeh et M et al. Observed similar results as our study, that is reduction in the postoperative pain with the use of gabapentin using preoperative preparation. And findings of Agrawal A et al., M et al. And Eliman et al. Were similar with our study results. We found that oral gabapentin 600 mg oral gabapentin 600 mg when given preemptively 1.5 hours before surgery reduces postoperative pain, reduces time for the first and second rescue anesthesia, and also decreases the total analgesic consumption in the postoperative period. Thank you.
Hello. Is the speaker with us?
Yes, sir.
Yeah, Dr. Anju Gautam. Yeah, nicely presented, right? And the topic was also good, right? I have one query, a small query for you, that certainly you have taken all sort of elective surgeries, and every surgery has a different pain profile. You know, how have you countered in your study this bias?
Sir, we have included mostly the studies of 1 to 2 hours, 2.5 hours. Like
because in some studies there may be more tissue damage, in some studies the tissue damage is less. So that may be one of the confounding limitations of your study, which you should be mentioning.
Okay, sir.
Right. That is one thing. Another thing is that you mentioned it was a closed envelope technique for randomization. Can you please elaborate on that?
Sir, nobody was known the study double blind.
I'm not asking about blinding. I'm asking about randomization.
So we have included
most of our they're postgraduates sitting with us and listening to this particular session. Most of you write that it is a computer generated random number table and a sealed closed envelope technique for randomization. But you should be knowing what exactly it is. It means that it's for the sake of writing, you all are writing it, right? And you haven't randomized your patients in the beginning. That gives that kind of an impression, you know.
Okay.
Thank you so much, Dr. Anju. Go back and look into it. What is sealed envelope technique, right?
Yes, sir. Yes.
Thank you. Next, please.
Hello, I'm Dr. Bhargavi, Senior Assistant at Tata Memorial Hospital. My topic is incidence and postoperative outcomes of acute kidney injury in patients undergoing major gastrointestinal surgeries. This was a prospective observation study conducted over a period of 1 year under the guidance of Dr. Vandana Agarwal. Acute kidney injury is quite common in hospital setup, especially in the postoperative period, incidence ranging from 18 to 47%. Our aim was to evaluate the incidence of acute kidney injury in the postoperative period and its long-term outcomes in patients undergoing major abdominal surgeries. After IEC approval and registration with CTRA, a study was started in August of 2019. Our primary outcome was to evaluate incidence of acute kidney injury. Secondary outcomes were to identify risk factors, morbidity, mortality, ICU and hospital stay, and need for renal replacement therapy, and long-term impact of acute kidney injury. These are the inclusion and exclusion criteria. Patients more than 18 years of age and undergoing elective abdominal surgeries were included as listed, and patients undergoing open laparoscopic or laparoscopic assisted and robotic procedures were all included. Patients less than 18 years of age, pregnant women, and patients already on dialysis, and patients with no baseline creatinine and available preoperatively and postoperatively were excluded from the study. 200 patients were screened over a period of 1 year, 170 were enrolled, and their various preoperative or intraoperative parameters were recorded. And they were patients who developed postoperative kidney injury were followed up over a period of 1 year. Acute kidney injury was staged according to KDIGO criteria. Various risk factors were identified associated with acute kidney injury with univariate analysis, and they were further analyzed with multivariate regression analysis for significant association. The incidence of acute kidney injury in our study was 19.4%, 33 patients developed acute kidney injury. Various preoperative variables were compared between the two groups that developed intraoperative, postoperative acute kidney injury and those who did not. None of the preoperative variables were found to be significantly associated, though more males had developed acute kidney injury compared to females. These are some of other preoperative variables. Among the surgical procedures, only retroperitoneal mass excisions done along with nephrectomies were found to be significantly associated with postoperative acute kidney injury for obvious reasons. Among the intraoperative risk factors, only intraoperative oliguria and targeted MAP not maintained within 10% of patients' baseline was found to be significantly associated with postoperative acute kidney injury. Oral complications was more skewed towards the acute kidney injury group. ICU stay and postoperative mechanical ventilation was significantly associated with acute kidney injury group, and so was mortality. Overall length of ICU stay and hospital stay remained similar in both group of patients. On multivariate regression analysis, target map not being maintained within 10% of baseline was found to be an independent predictor of acute kidney injury in the postoperative period, so was nephrectomy. 33 patients who had acute kidney injury were followed up in the long term. At the time of discharge, 66% of the patients had recovered and 21% had acute kidney injury persistently. At 1 month follow-up, 6% had persistent acute kidney injury in stage 1 of kidney and 3% in stage 2, and 84% had recovered. At 6 month follow-up, 6% had persistent kidney injury in stage 1 and 93% had recovered. And at 12 month had persistent kidney injury at stage 1 and 96% had recovered. Acute kidney injury associated with poorer outcomes, incidence in literature range from 1.4 to 24%, our incidence is 19.4%. And among the preoperative risk factors, none of the factors were found to be significantly associated, though males were found to have more chances of acute kidney injury as compared to females. And we observed no association with intraoperative hypotensive episodes of vasopressor use and acute kidney injury, but intraoperative oliguria and targeted mean arterial pressure not within 10% of the baseline was found to be significantly associated and also was a independent predictor for postoperative acute kidney injury. To conclude, identifying high-risk patients preoperatively and utilizing hemodynamic targets and fluid management strategies can help in reducing incidence of acute kidney injury, which has the potential to progress into chronic kidney disease. These are my references. Thank you.
Yeah, thank you. Are you with us today?
Yes, sir. Yes, sir.
Yeah, Dr. Bhargavi.
Yes, sir.
Yeah, Dr. Bhargavi, a very well thought presentation, right? It's much different than what others out of box thinking, I must say, right? My question to you is that is there any role of an intraoperative fluid therapy in postoperative AKI detection?
We did actually compare, so according to our hospital protocol, we actually calculate the patient's ideal body weight, and intraoperatively we give maintenance fluids at the rate of 3 ml per kg per hour. So we did not change any methods. So we just observed if there was any difference between total amount of IV fluids infused over the whole intraoperative
So have
period.
you used colloids or crystalloids only?
No, we have just compared whatever they have used. So we have even compared whether how much of crystalloids was infused, how much of colloids were infused if they have.
Unless and until you will, unless and until you will standardize this thing, unless and until you standardize your fluid therapy, right? So measuring, looking for post-operative outcomes and something, that creates a bias into that, right? That is particularly there. If you use more of a colloids, the chances of renal involvement may be more. Rather, in major abdominal surgeries these days, any kind of a fluid therapy which is advisable to give to prevent AKI? Is there any specific kind of a fluid therapy advisable to prevent AKI in major abdominal surgery?
Now, actually, studies are coming up saying there is no difference between restrictive and liberal fluid approaches.
Excellent, excellent.
So,
right, because there was a lot of discussion about a goal-directed fluid therapy, right? That is there, in which you go for an invasive monitoring like SVV and cardiac index monitoring. Depending on that, you give fluid in major abdominal surgeries.
Yes, we do
right?
do that.
Yeah. So if you could have standardized your fluid therapy, your study could have been even better, right?
Yeah.
Yeah. Thank you so much, Dr. Bhargavi.
Thank you
for joining us.
Hi everyone, today I am presenting the paper on comparison of intranasal dexmedetomidine versus intranasal midazolam in prevention of emergence agitation in pediatric age group undergoing adenotonsillectomy, a randomized controlled trial. Emergence agitation is a complex behavioral disturbance characterized by thrashing, kicking, disorientation, inconsolable crying, cognitive and memory impairment after general anesthesia. This can result in marked hemodynamic changes with increase in dose of analgesic, sedation, length of hospital stay, and parental anxiety. Hence, this study was undertaken to prevent the same. Intranasal route was preferred as it is easy, non-invasive route with rapid onset of action due to high vascularization of nasal mucosa. Objective of this study was to compare the effect of intranasal dexmedetomidine versus intranasal midazolam in prevention of emergency agitation after adenotonsillectomy. This study was undertaken at Gadag Institute of Medical Sciences, Gadag, between December 2020 to August 2021 after obtaining written informed consent from parents and ethical committee clearance. Inclusion criteria were ASA 1 patient and age group 3 to 8 years. Exclusion criteria were allergic to study drug, children with developmental delay ASA 3 and 4 patient. Sample size was calculated using this formula where we obtained number of samples as 19. For ease of calculation, we have taken 25 patients in each group. Written informed consent was obtained on the day of surgery and NBM guidelines were followed as 6 hours for solids and 4 hours for liquids. The children on the day of surgeries were allotted on as group D as dexmedetomidine group or group M midazolam group on the basis of randomized computer generated table. Patients who met criteria were attached with standard monitors. Patients were pre-medicated with injection glycopyrrolate, midazolam and fentanyl. Induced with injection propofol 1 mg per kg body dose IV, after which intranasal administration of respective study drug was given. Group D received 2 mg per kg intranasal dexmedetomidine, whereas Group M received 0.2 mg per kg intranasal midazolam. 4-point agitation scale was measured at extubation, leaving OR on arrival at PACU 5, 15, 30 minutes after arrival at PACU. 4-point agitation scale is score 1 for awake, calm and cooperative child, whereas score 4 for combative, disoriented, thrashing child. Results obtained were calculated for both the groups and compared by use of analysis of variance test, and Mann-Whitney test was used to calculate significance in both the groups. This chart shows emergency agitation score at the time of extubation. It was between 1 to 2 in group D and 1 to 3 between group M. On leaving OR scale was 1 in group D, 1 to 3 between group M. On arrival at PACU 5, 15, 30 minutes in both the group, it was score 1. At the time of extubation, 15 patients had score 1 in group D, 9 patients in group M, and 10 patient in group D had score 2, whereas 12 patient in group M had score 2. 4 patient in group M had 3 score. This bar chart shows the same. It was noted that group D had better hemodynamic. It was noted that group D was better in comparison to group M. This study noted that group D was better in prevention of emergency agitation in comparison to group M. However, in both the groups, hemodynamic parameters were stable. It was also noted that intranasal route is effective, easy and non-invasive routine, both and rapid onset of action due to high vascularization. Similar articles were found in Asian Journal of Anesthesiology and Egyptian Journal of Anesthesia. Hence, our study concludes that intranasal dexmed is better in prevention of post-op agitation in children undergoing adenotonsillectomy in comparison to intranasal midazolam. However, both the group had better hemodynamic stability. These are the references. Thank you.
Thank you so much, Dr. Zakia. Are you with us? Hello. Is Dr. Zakia with us for question answers? Dr. Zakia, you have to unmute yourself.
Hello, sir. Good morning, sir.
Good morning. A very pleasant morning, Dr. Zakia. And
Yes,
you have used intranasal routes. My 2 queries for you. Number 1, do you
Yes,
think that the dexmedetomidine is FDA approved for intranasal use?
Sir, it's not yet approved, sir. So we are just trying whether we can use it and we can get like any results with the same.
Because for publishing it in a standardized journals or something, the drug has to be FDA approved. Do you know that?
Yes, sir.
So till date, for what purpose do you feel that dexmedetomidine is FDA approved?
Sir, for analgesic use, it is approved, sir. Dexmedetomidine, and also
No.
for procedural sedation, it is approved, sir.
Till date, just there is one indication and one route only FDA has approved dexmedetomidine. The
Yes,
route
sir.
is intravenous, and the this thing indication is ICU sedation. or as a continuous infusions. That is the only and only, although we all throughout the nation are using dexmedetomidine by various routes, even somebody is mixing it with subarachnoid block, local anesthetic also, and doing the studies. But FDA approval is just for ICU sedation as a condition for all postgraduates listening to us, right? That is there today morning, right? That is one thing. Another thing is, Dr. Zakia, why do you think that in your study, dexmedetomidine has been proved better than midazolam through intranasal route?
Sir, mainly I have focused on emergency agitation during extubation, sir, immediately after extubation. So in
why
my
do you think the emergency agitation was less with dexmedetomidine? What may be the reason?
Sir, one thing we can, midazolam is one thing is that I'm giving it immediately after induction. So midazolam is in comparison with dexmed, it is short acting, sir, in comparison with dexmedetomidine. So I think one, and dexmedetomidine has also analgesic property, and maybe that might be the cause I found it better compared to midazolam. But in all the cases we have used sevoflurane, sir. Maybe we could have avoided sevoflurane also, because sevoflurane is also known to cause emergency agitation.
Exactly. I was coming to that point which you have yourself targeted. That is one limitation in your study, right?
Yes,
if you use other inhalational, it would have been better, right?
Yes.
Thank you so much, Dr. Zaki, and all the best.
Thank you, sir.
Next, please. Tech team, please, next.
A very good day to all the participants of 68th National Conference of Isacon. I'm Dr. Priyanka Singh, Senior Resident at RIMS Raj. The topic of my presentation is post-operative pain control after lower segment cesarean section, a comparative study between transversus abdominal spleen block and local anesthetic wound infiltration with 0.5% ropivacaine. Introduction. Pain remains the most common and dissatisfying problem experienced by patients in postoperative period. Conventional methods of pain control using opioids is no longer preferred because of the number of side effects associated with it. Local anesthetic wound infiltration helps reduce postoperative pain, and its use has been a common practice in medical institutes for a long time. In transversus abdominis plane block, local anesthetic is infiltrated in the plane between transversus abdominis muscle and internal oblique to block nerve fibers from T6 to L1. It has been used to provide analgesia for various surgical procedures. Aims and objectives. Aim is to compare postoperative pain relief between local wound infiltration and tab block using 0.5% ropivacaine after lower segment cesarean section. Material and methods. This is a prospective randomized study conducted at Department of Anesthesia at RIMS Ranchi. Total of 60 female patients were enrolled who were posted for cesarean section. Study period was 1 year after ethical committee approval. Process of randomization was done by allocating a computer-generated random number table. Double blinding was done by blinding the patient observer who was assessing the severity of the postoperative pain. Sample size was calculated based on previous studies. Inclusion criteria was patient's consent, patients between 20 to 40 years, weighing 40 to 60 kg, ASA grade 1-2. Exclusion criteria, patient's refusal, patient not belonging to the inclusion criteria, not fulfilling the inclusion criteria, patient having history of allergy to local anesthesia, patient with contraindication for spinal anesthesia. Materials and methods, 30 patients were randomly given tap block, 30 were given local anesthetic infiltration. VAS score was recorded at 60 minutes post-op, then at 2, 4, 6, 12, 24 hours to compare post-operative pain intensity. The time to first analgesia request in both the groups was also recorded and compared. Also, the total dose of rescue analgesic was given and was recorded. Once the operation ended, all vital parameters like BP, heart rate, respiratory were recorded at regular intervals. Any other side effect like nausea, vomiting, pruritus was also noted. Observations and results were recorded and tabulated and in a graphical manner. As we can see, this is a table comparing the demographic profile of both the groups. Both the groups are comparable with respect to age, height, weight, ASA category, and nulliparous status. With p-value greater than 0.05, this is a table comparing the VAS score in the postoperative period. As we can see, the VAS score at first, second, and 12th and 24 hours is statistically significantly higher in the local anesthetic wound infiltration group than the TAPS block group with p-value less than 0.001, while VAS at 4th and the 6th time, both the groups are comparable with p-value greater than 0.05. This is a table comparing cumulative dose of rescue analgesic used in milligram. Group A, the TAPS block group used around in mean value of rescue analgesic use was 100.36 milligram, while in group B, the mean value was 189.16, which is much higher and statistically significant with p-value less than 0.001. This is a graphical demonstration of the same. This is a table comparing the request for first rescue analgesic in minute, time for comparing the time of request for first rescue analgesic in minute, while in group A, the time was 678.43 minutes, while in group B, it was 236.06 minutes, p-value less than 0.001. This is a graphical representation of the same. This is a table comparing the side effects. This is a table comparing the side effects in both the groups. As we can see, both the groups are comparable with respect to the incidence of side effects like nausea, pruritus, bradycardia, incidence of hypertension. Discussion. In this study, we have tried to compare local wound infiltration TAPS block for postoperative pain relief in cesarean section. Local wound infiltration is a commonly used procedure in hospitals, especially in settings where ultrasound machine is not available. The procedure is easy to perform, doesn't need any expertise or any other special instrument, and can be performed by the operating surgeon. The advantages of TAPS block for postoperative pain relief has also been described in literature. There are many studies that compare TAPS block with placebo, but not much study material is available which compare TAPS block with local wound infiltration at the surgical site. In a study by McMurrow, they compared TAPS block added to subarachnoid morphine in patients who underwent cesarean section. They found that TAPS block did not give any added benefit over intrathecal morphine, probably because it acts only on the nerves of anterior abdominal wall, whereas morphine acts both on the visceral and the parietal level. But the use of intrathecal morphine is associated with many side effects. A meta-analysis showed that the use of local anesthetic wound infiltration provides better pain relief in postoperative period and also decreases the incidence of PRV. The findings in this study are supported by RCT done by Adognos, which showed numeric pain score 2, 6, 12, and 24 are to be statistically significantly higher in local anesthetic wound infiltration group than the TAPS block group. In this study, also the VAS score at first, second, 12th, and 24 hours found to be statistically higher in the LAI group than the TAPS block group. Conclusion: we can conclude that TAPS block, when compared to local wound infiltration, does show better pain relief in the initial few hours of a C-section and also provides longer duration of analgesia. TAPS block significantly lower the cumulative dose of rescue analgesic and delay the demand of rescue analgesia. So TAPS block can be recommended for all patients undergoing cesarean section, and larger multi-center trials are needed to establish the usefulness of TAPS block for postoperative pain relief instead of local anesthetic wound infiltration. These are the references, and thank you.
Is Dr. Priyanka with us? Dr. Priyanka with us for question and answer? Do we have Dr. Priyanka? I can't see her in this. Just a quick remark for all postgraduates who are listening me today, though Priyanka is not with us, right? Any study which you are presenting or conducting on a pregnant patient, the last study was cesarean section, right? That is it. Any pregnant patient is always ASA 2 and above. Pregnant patients are never ASA 1 patients, right? They are considered as ASA 2 patients and above. So this Priyanka has statistics also on ASA 1. I don't know how she, got pregnant ASA 1 patients, which is not true at all, right? So for all postgraduates, don't commit this mistake next time. Thank you. Next presentation from tech team.
I am Dr. Amur Osraju, Junior Resident in Department of Anesthesiology in AIIMS Patna. Today I am going to present before you a case series on ultrasound-guided selective musculocutaneous and radial nerve block for radiocephalic arteriovenous fistula creation in patients with renal failure on dialysis. We did this case series on end-stage renal failure patients on dialysis who came to us for arteriovenous fistula creation. As we all know, patients with end-stage renal failure constitute a vulnerable subset of patients for any anesthetic intervention. In this case series, we selectively block the musculocutaneous nerve and radial nerve in 9 consecutive end-stage renal failure patients requiring radiocephalic fistula creation under ultrasound guidance using 5 ml of 0.25% bupivacaine each. This is the ultrasound image of the radial nerve in the radial groove. This is the shaft of humerus. Here it is clearly visible that there is no vascular structure in the vicinity of the radial nerve. This is the ultrasound image of the musculocutaneous nerve. This is the coracobrachialis muscle and this is the biceps brachii muscle. Here also there is no vessel in the vicinity of the nerve. The outcome was noted by assessing the intraoperative and postoperative pain using numerical rating scale in patients who were complaining of pain intraoperatively, that is in NRS was more than or equal to 4 on 10. We asked the surgeon to give subcutaneous infiltration using 1% lignocaine and it was noted down as additional local anesthetic supplementation. At the time of incision, all patients had satisfactory pain control. However, intraoperatively, in 2 patients, sensory sparing was noted and they required additional local anesthetic supplementation. In 2 other patients, procedure was abandoned due to surgical difficulty in fistula creation. No patient complained of postoperative pain. The patients undergoing dialysis are generally elderly aged and they may be debilitated also. They may be having multiple comorbidities. So there is an increased risk for general anesthesia. This regional anesthesia is the recommended approach for fistula creation in these patients. But there have been only a few studies comparing the use of selective nerve block and brachial plexus block for AV fistula creation, such as that by Yazigi et al. And Matsuda et al., which conclude that selective nerve block can provide efficient anesthesia for AV fistula creation. This also for the creation of AV fistula creation, motor nerve block is not necessary, and so we can go for selective nerve block in such patients. Also, in the selective nerve block, we need only a low volume and low concentration of local anesthetic for the creation of AV fistula, and also there is less chance of vascular injury in selective nerve block, and also this has got a faster learning curve. The limitations of our study was it was a case series study design and there was no randomization or blinding was done, and to confirm the findings we need more cases to be done. We conclude that ultrasound guided block of musculocutaneous and radial nerve could be an effective method in providing anesthesia for creating radiocephalic arteriovenous fistula, but prospective studies need to be done to confirm their efficacy. These are our references. Thank you.
Nice presentation by Dr. Amu. Dr. Amu, are you with us this morning?
Sir, good morning, sir.
Yeah, good morning. Good morning. Certainly a good topic for a case series, as you already mentioned that it's there's a limitation is that the blinding and randomization was not done yet. I just noted this little problem in this particular series, but yes, I really wish that if you guys convert it into a case study kind of a thing, and you may get some good results, and you may get a good indication, right? So that is particularly right. So are there any studies available comparing the combination of these 2 blocks versus the brachial plexus block?
Sir, in the references, there was only one study that was done as such. Only 1 or 2 studies. Limited number of
You have thoroughly searched the literature?
Yes.
Okay. So-
Sir, as far as I have searched, I found out only 3 studies maximum. That was for comparing. One study was exactly similar to our study, and
Okay.
there was one study comparing this regional anesthesia versus this thing, like brachial plexus block versus this selective muscular cutaneous and radial nerve block, and then we comparing regional anesthesia and local infiltration. So.
In those studies, were there any difference in the dose of the total volume of the local anesthetic used in the two techniques?
Sir, in selective musculocutaneous and radial nerve blocks, we need only low volume. Low volume and low dose can provide the desired anesthesia effects. Sir.
Yeah, what was the total volume difference in the studies which you have read?
Sir, in our study, we used
Because
only
that is
5.
one of the advantage of your case series. You mentioned that it avoids your, this thing, brachial plexus block and general anesthesia and those subset of patients, right? So that is
Yes.
there. So these are old patients as well, can gather, mostly coming to you for dialysis. So what was the exact dose reduction?
Sir, if you are giving brachial plexus block, at least 15 to 20 ml of 0.5%.
Yes.
But in the study, we used only 5 ml of 0.25% bupivacaine was used.
How much?
Dosage was also half done. Volume became from 15 to 5 ml. Like 15 to
5
20, we
ml.
needed only 5 ml.
Yeah, that is one of the biggest, asset of your case series, which you should be mentioning and knowing about it. Because
Yes,
most
sir.
of the time, the toxicity and everything depends upon the dosages which you guys are using. Right?
Yes,
That is
sir.
one last query to you, that if you have to convert this into the case study, right, then
Yes, sir.
what kind of a blinding principle you should be going through?
So it should be double blinded. Sir.
Okay, how can you double blind it?
So both the observer should be blinded, and also the patient should also be blind. Patient cannot be blinded. So observer should be blinded, sir, for better effects. Hello. So,
Single blinded then, right?
Single blinded, sir.
Okay, thank you so much and all the best.
Okay, sir. Thank you, sir. Good news.
Next presentation from the tech team, please.
My topic is comparative study of intrathecal bupivacaine and levobupivacaine with fentanyl for cesarean section, a prospective randomized controlled double-blinded study. Principal author Dr. Jignesh Kamalia, co-author or PG guide Dr. Shilpa Doshi. My college is Government Medical College Bhavnagar. Introduction. Levobupivacaine is a S-enantiomer of bupivacaine. It is a long-acting local anesthetic, provides more selective neuraxial blockade. It is less cardiotoxic and neurotoxic than bupivacaine. Its basicity offers an advantage of providing a less position-sensitive blockade. Aims and objective. Aim to compare the effect of intrathecal administration of hyperbaric bupivacaine and 10 microgram of fentanyl with 0.5% isobaric levobupivacaine and 10 microgram of fentanyl in cesarean section with respect to compare and assess sensory and motor block hemodynamic parameters, first request for analgesic and neonatal outcome. Primary objectives of the study: to compare the onset, peak duration and regression of sensory blockade, to compare the onset, peak duration and regression of motor blockade and duration of analgesia. Method. After IRB approval in informed written consent, my study was conducted in Department of Anesthesiology, Government Medical College, Bhavnagar, Gujarat, India. Patient who was undergoing cesarean section under spinal anesthesia. Inclusion criteria and exclusion criteria. Observation and results of my study. Table 1 shows that the patient's demographic parameters in terms of age, weight, height, and duration of surgery was comparable in both the groups, where the p-value is statistically significant. Sensory characteristic, the time to onset of sensory blockade, time to attain T6 sensory level, and time to regression of sensory blockade, means duration of sensory block, were significantly lesser in group B in compared to group L. Motor characteristic, the time to onset of motor blockade and time to maximum motor blockade attained were significant lesser in group B in compared to group L, whereas time to regression of motor blockade was significant high in group B in compared to group L. Duration of analgesia, the time for first request of analgesia were significant longer in group L. Hemodynamic parameters, heart rate and SpO2 were comparable in both the groups, whereas fall in systolic blood pressure were significant from 10 minutes to 40 minutes in group B. Side effect, incidence of hypertension was significantly less in group L in compared to group B. Other side effects like bradycardia, vomiting, were comparable in both the groups. Discussion. The time for onset, time to peak, and time to duration of sensory blockade were significantly lesser in group B. The time to onset, time to peak of motor blockage were significantly lesser in group B in compared to group L. The duration of motor blockade was significantly prolonged in group B. The duration of analgesia was significantly prolonged in group L. We recorded that incidence of side effects such as hypotension, bradycardia, and vomiting were more in group bupivacaine. Conclusion. It is concluded that the bupivacaine had prolonged sensory blockade, prolonged analgesia, earlier regression of motor blockade, stable hemodynamic, and decreased incidence of adverse effect. So bupivacaine is less cardiotoxic and had no adverse effect on neonates. References. Thank you.
Yeah, thank you so much. Is this Jignesh with us? I can see Jignesh is with us today. Yeah, Jignesh, you have to unmute yourself. And Dr. Jignesh, if you can unmute yourself.
Hello, hello.
Yeah, Dr. Jignesh, I'm able to hear you now.
Hello, good morning, sir.
A very good morning. Very good morning. You are from a beautiful city of Bhavnagar. I visited Bhavnagar in 2010, right?
Yes,
in your medical college for one of the conferences, and it's an amazing campus which I liked almost 11 years back, right? And that is there, and a good study you have conducted. But really want to ask that any incidents of cardiotoxicity you have seen with bupivacaine during your study? Because your conclusion says levobupivacaine is less cardiotoxic.
yes, sir. No, sir. I have not seen any study, any cases of bupivacaine toxicity, sir.
Yeah, that is there. So your conclusion of the study should always be the findings which you have got, right? It should not be an open-ended conclusion. This statement is an open-ended thing that the levobupivacaine is less cardiotoxic. We all know that. But you are presenting the discussion and conclusion of your own study, right? So
yes, sir. Yes, sir.
whenever you are presenting that, restrict to your study rather than an open-ended statements. Yeah, number one. Again, a suggestion to you for slide making, your discussion was again whole paragraph, right? The important points be in a shorthand you have to write on slides or PPT, right? So that anybody can easily collect, that is there.
Right, sir.
Any point in your study, any point in your study favors bupivacaine over levobupivacaine?
Hello.
Any point in your study favors bupivacaine over levobupivacaine? Dr. Jignesh? Dr. Jignesh? Jignesh, are you able to hear me? think Jignesh has logged off. So we can move to the next one, Ms. Priya.
Respected judges and delegates, I am Dr. Saurabh Das, presenting today effects of head position on awake orotracheal intubation by fiber optic bronchoscope, a randomized control trial. The incidence of difficult airway ranges from 0.3 to 13%, and nearly 30% of all anesthesia-related deaths are attributed to difficult airway. Awake fiber optic bronchoscope intubation is considered gold standard management of difficult airway. The aim of the study was to investigate the effects and safety issues of 3 different head positions on awake orotracheal intubation via fiber optic bronchoscope. After ethics committee approval and written and informed consent from the patients, this prospective randomized study was conducted in MKCC Medical College from January to August 2021 with 75 adult patients. Inclusion criteria being AC physical status 1 and 2, modified Mallampati grade more than or equals to 3, undergoing surgery under general anesthesia with anticipated difficult intubation, age more than 70 or less than 18, cervical vertebral disease, loose or missing incisors, preoperative hoarseness, bronchial asthma, history of airway hyperresponsiveness, hypertension, and abnormalities of heart, brain, liver, lung, kidney, and coagulation profiles were excluded from the study. Preoperative evaluation was done, and patients were randomly allocated into neck in neutral position group with occiput close to the operating table, neck in sniffing position group with a 7 cm pillow under the occiput, or neck in extended position group with a 7 cm pillow under the shoulder and occiput close to the operating table by computer generated codes. Lignocaine nebulization and gargling was done with 4% lignocaine. Standard monitorings were attached. Awake fiber optic bronchoscopy was done, and 2 ml of 1% lignocaine was sprayed through the bronchoscope after visualization of vocal cords. Coughed ET tube of size 6.5 mm and female and 7 mm for male were used. The time to view vocal cords, which is defined by the time from inserting the fiber optic bronchoscope between the teeth until the operator view of entire vocal cord was recorded. Also, the time to insert the tracheal tube into trachea, the percentage of glottic opening score, and the VAS score for age experienced during passing the tube through the glottis, the hemodynamic changes during intubation, and the adverse events after surgery were recorded. The sample size was calculated with significance set at 0.05 and power at 80%. Analysis were performed using SPSS 17 statistical software. Continuous variables were presented as mean plus or minus standard deviation, and the difference among the groups were compared with ANOVA. P-value of less than 0.05 was considered as statistically significant. From our study, we found that there was no significant difference in patient demography. The time to view vocal cords was significantly shorter with a p-value of 0.01, and the POGO score was significantly higher with a p-value of 0.02 in the extended position group compared with the other two groups. The time to insert the tube, the VAS score, mean arterial pressure, and heart rate had no significant differences among the three groups. Also, there was no significant difference in post-operative throat pain or hoarseness of voice. Hence, we conclude that neck in extension position had better view of glottic opening than neutral position or sniffing position during awake fiber optic bronchoscope oral intubation. Hence, neck in extension position was recommended as the starting head position for oral awake fiber optic bronchoscope intubation. Thank you.
Thank you so very much, Saurav. Saurav, are you with us? I can see you.
Yes, sir. Good morning, sir.
Yeah, very good morning and pleasant morning. A good topic, excellent topic, and topic of my interest, airway, right? That is there. And because I have my own team to conduct advanced airway workshops, I keep on traveling. So that is one good topic, very close to my heart, right? So I have few things for you with my experiences, which I want to say is that any specific reason you selected an oral route for doing awake intubation rather than the nasal one?
So in nasal route, we had to do additional local application of jelly and all, and that would irritate the nasopharynx.
Which one do you think in a difficult intubation cases or an awake fiber optic intubation is a better route, and why?
So for awake, nasal route could have been better.
Yeah, certainly. Awake nasal route is much, much better. Alignment is much better with the nasal route. Patient cooperation is much better. There are chances of damaging, the fiber optic bronchoscope if you're doing an awake oral intubations, right? So it's safer from all point of view. I suggest that if you conduct a study on an awake fiber optic intubation, if there's no contraindication, right, you should be using a nasal route. That is, the success rate goes up, the cooperation goes up, right? So that is again the big advantages. So what do you use during your cases to prevent the damage to fiber optic bronchoscope?
Sir, we're using the airway, sir, Goodell's airway.
Goodell's airway.
Sir, in some patients we're using that.
Are you sure you have used Goodell's airway?
Sir, in one patient we had to use Goodell's airway, and we're using the side by side of fiber.
And how about other patients?
So other patient we're just telling them to open the mouth and.
Oh, very risky, very risky. It's an costly equipment, you're dealing with. If at all you are doing oral fiber optic bronchoscopic guided intubation, you should be having something known as Ova sapiens airway, right? That is there. It is almost similar to the Goodell's airway with guiding channel, right? That is there. Or you can use any kind of a bite block or kind of a prop, right? That is there. So in order to prevent this, if you're not using any bite block, right, it's not ethically correct, right? So that is it. This is for my all postgraduates. One more thing which I want to say, that POGO scoring system which you have used, right? POGO scoring system is mainly for a glottic view by video laryngoscopes.
Okay.
Right? POGO scoring system is generally not advisable and not used for fiber optic bronchoscope grading. For fiber optic bronchoscope grading, the score which is used is, do you have any idea? That is BRIMACOM scoring.
Okay.
Right? That is a standard scoring system to grade the glottic view by fiber optic bronchoscope, right? So this is learning this thing for all postgraduates listening to me in the morning. Thank you so much, Saurav.
Thank you, sir.
Next from the tech team.
Good morning. My title for e-paper is Comparison of Endotracheal Tube Position with Head in Neutral versus Extended Position using Ultrasonography. Introduction. Oral endotracheal intubation is a routinely performed procedure in elective surgeries. Various formulae have been created to determine the adequate size of tube for patient. In pediatric patients, formulae have also been made to determine the depth of insertion. However, in adults, adequate depth of insertion is usually confirmed by bilateral lung auscultation, chest radiography, or fiber optic bronchoscopy. Ultrasonography has been increasingly in use for confirming depth of insertion. Airway distances like vocal cord cup distance has been measured using ultrasonography to ascertain adequate insertion depth. Manipulation of head and neck during surgery can displace the tube, resulting in carinal stimulation, vocal cord impingement, accidental endobronchial intubation, or even extubation. This study aimed to determine the significance of sepallar displacement of the endotracheal tube. Objectives. Primary was to measure the vocal cord cup distance with head in neutral and extended positions. Secondary objective, to determine the significance of sepallar displacement of endotracheal tube. Materials and methods. Type and design of study, prospective and observational. Study location, KLE's Dr. Prabhakar Kore Hospital. Study population, 68 patients aged between 18 and 60 years of ASA 1 and 2 status undergoing elective surgery under general anesthesia with oral endotracheal intubation. Ethical clearance obtained. Exclusion criteria, patients who did not give consent, ASA 3 and 4, and any cervical pathology. Sample size estimation was done based on prevalence of successful intubation, and statistical analysis was done using students' unpaired t-test. A linear transducer of 13 to 6 MHz with transverse orientation was used to locate the vocal cords and externally mark the level of vocal cords before intubation. Males were intubated with 8.5 mm internal diameter and females were intubated with 7.5 mm internal diameter tracheal tubes, which was then fixed at 22 cm in males and 20 cm in females. The cuff was inflated with saline of 4 to 5 ml. Using the linear transducer with longitudinal orientation, the proximal end of the saline inflated cuff was located and externally marked. The distance between points A and B were measured with head in neutral and extended positions. This was the vocal cord cuff distance, that is VCD. Normal VCD was 1.5 to 2.5 centimeters. Results: mean difference between VCD in neutral position and VCD in head extended position was 0.56 plus or minus 0.091 centimeters. The number of observations with VCD in extended position below 1.5 centimeters was 33, while above or equal to 1.5 centimeters was 35. 2 patients had a VCD less than 1.5 centimeters when head was in neutral position, while 33 patients had a VCD less than 1.5 centimeters when head was in extended position. This difference showed to be significant with a p-value of 0.019. Discussion: head extension is known to cause upward displacement of endotracheal tube. Previous studies have used fiber optic bronchoscope to measure the extent of tube displacement while manipulating head and neck during surgery. Utilization of airway ultrasonography has been on the rise to measure airway distances like vocal cord cuff distance to ensure safe depth of insertion. Our study used this airway distance to determine the extent of cephallar displacement, which proved to be significant. On concluding, head extension causes a cephallar displacement of about 0.56 plus or minus 0.091 centimeters and is significant, endangering vocal cord impingement or even accidental extubation. Hence, in anticipated head extension during surgery, we advise a tube be placed 0.5 to 0.6 centimeters deeper than it is usually done. These are the references. Thank you.
Thank you, madam. Are you with us today?
Yes, sir. Good morning, sir.
Yeah, very good morning. Very good morning. Excellent. A very novel idea, I must say that because we have been using fiber optic bronchoscope earlier, as you also said, right? And utilization of sound that made the life so easier. My question to you is that a displacement of 0.5 centimeters, can you feel the accidental extubation can occur?
No, sir. My opinion on this would be that more than accidental extubation, the risk would be impingement on the vocal cords.
How much? My question is, how much deep your tip of the tube is through the vocal cords generally?
Sir, it's usually at least 2 centimeters below the vocal cord. That if we fix it at the black mark that is there on the ET tubes, endotracheal tubes, it is at least 2 centimeters below the vocal cord.
It's an age-old teaching, Dr. Sridhanya, that the tip of the tube has to be a mid-tracheal position. Right,
Yes,
that is somewhere around mid-tracheal. Mid-tracheal position is somewhere around nearly 3 to 4 centimeters away from the vocal cords, and similarly 3 to 4 centimeters above the carina, right?
Yes,
keeping
sir.
the trachea
Yes,
of 10 centimeters approximately, right? That
yes,
is there.
Sir. Yes, sir.
So if it is well beyond 3 centimeters or so, a displacement of 0.5 centimeters neither impinges the vocal cords nor lead to accidental extubation, right? That is there.
Sir.
Did you find it in any of the cases that your tube, when in head and extension, your tube has come out?
No, sir. There was no accidental extubation, but because I used this vocal cord cuff distance measurement. In that, I got 50% of the subjects had an distance less than 1.5 centimeters, which means the proximal end of the cuff was closer to the vocal cord according to my measurements. But there was no accidental extubation that I had observed. Vocal cord impingement, we hadn't evaluated post-operatively or post-extubation if the patient
of your study to tell your study has some value. You know, these should be the outcomes of your study.
Yes,
right?
Yes,
That's
sir.
Yes,
sir.
Thank you
Since
so
mine
very
was purely observational, we hadn't measured the outcome. So that could have been done.
Yeah. Thank you so very much and all the best.
Thank you, sir. Thank you so much.
Next, please.
Good morning. I'm presenting a paper on comparison of the effect of phases of menstrual cycle on the injection pain due to propofol and the injection dose of propofol, a prospective double-blinded study. Propofol is almost an ideal IV anesthetic agent, but the pain on its injection remains a problem, which is often remembered as an unpleasant encounter by the patient. This pain can be immediate due to direct irritant effect of phenol or delayed due to indirect effect via kinin cascade activation. This propofol pain injection can be varied in human females because of of varying levels of hormones in the blood. Very few studies exist about the effect of phases of menstrual cycle on propofol pain, and previous studies that combat pain sensitivity in the phases of menstrual cycle had controversial results. The primary objective is to combat the effect of different phases of menstrual cycle on the pain response to propofol injection and to combat the dose requirements of propofol for the induction of general anesthesia. And the secondary objective is to find out whether the pain is early pain or late pain. After obtaining Institutional Ethical Committee approval and CTRI registration, the study was conducted in female patients of age 18 to 45 years of ASA grade 1 and 2. The sample size was calculated after considering the mean standard deviation variance of the study conducted by Volk and Hansi. The sample size was calculated to be 50 with 25 members in each group, group F for follicular phase and L for luteal phase. The patient was induced with injection propofol 30 mg IV every 10 seconds and pain was assessed using verbal rating scale. The type of pain was also noted. After a total of 60 milligrams of propofol injection, the patient was checked for eyelash reflex and if it was positive, additional bolus doses were given until the patient was induced. The data was entered in Microsoft Excel and analyzed using Stata version 12. Continuous variables were summarized using mean and categorical variables were summarized using proportion. The comparison of continuous variables were done using sample t-test and categorical variables were done using chi-square test. When comparing the presence of pain between study participants, it was found that 92% of follicular phase had pain compared to 96% in luteal phase. Comparing the pain intensity, it was found that 54% of patients in follicular phase had slight pain compared to 52% in luteal phase, and 28% in follicular phase had moderate pain compared to 44% in luteal phase. 84% of patients in both the groups had delayed pain due to propofol injection. On comparing the dose requirement of propofol, it was found that an average of 97.6 mg was required in follicular phase compared to 97.2 mg in luteal phase. In this study, we demonstrated that there were no significant difference in injection pain scores of propofol in both phases of menstrual cycle. And both the groups had comparable demographics, and it was found that majority of the patients in luteal phase had more pain compared to group F. However, it was not statistically significant. And also it was found that majority of patients in group F had slight pain compared to group L, where majority had moderate pain. In a prospective double-blinded observational study, Hansi et al. Showed that luteal phase had greater pain scores than follicular phase. Also, the mean propofol dose requirement was found to be more in follicular compared to luteal phase. However, it was not statistically significant. In an old study by Few et al., he found that the luteal phase required less propofol dose. Limitation of the study was patients were categorized based on LMP and USG rather than measuring the blood levels of estrogen and progesterone. And also, subjective measurement of pain score was used. Concluding, menstrual cycle phase has little effect on the severity of propofol injection pain and injection dose of propofol. More studies are required investigating not only the injection pain of propofol but also different types of pain using more objective pain scores. And also, the pain due to propofol is due to irritation of venous adventitia due to activation of kinin cascade, that is delayed pain. My references. Thank you.
कितना टाइम लगाओगे आप?
Hello.
Hello.
Good morning, sir.
Yeah, good morning. Good morning. A novel thought, I must say, because I have never come across this kind of a study till now, right? That is there. What made you think that the pain of the propofol injection goes down with the menstrual phase?
Sir, actually, there haven't been much studies comparing the pain in both the menstrual cycle phases. So I wanted to do that. And as being anesthetist, propofol is the most common induction agent.
That is there. But what may be the mechanism of pain on site of injection relief from the menstrual thing?
The sensitivity to pain is compared, sir, so that it is like progesterone will increase the sensitivity to pain. So that is what I wanted to study, like check, sir.
Okay, okay. So because propofol pain is mainly due to, you might be knowing the why there is a pain in the propofol injection,
Yes,
right?
sir.
Maybe due to the lipid component of that is soybean oil, which causes pain on injection, right?
Yes,
So
sir.
that is there. So it's there only, right? It's only the perception may be a different thing, right? Because of that, but the pain still remains there because there is nothing which prevents the pain or something like that.
Yes,
Right.
sir.
And what were the subset of patients which you took for the study?
The between reproductive age groups are like around 15 to 45 age was the study population, sir. And
Mother, coming for what kind of a surgery?
like usually the patients which I took were undergoing ENT surgeries, sir, like mostly adenoid and CSOM. Those cases, sir, like who were in ASA 1 and 2 groups, sir, and also fibroadenoma cases.
Okay, the short procedures mainly?
Yes, sir. CSOM, that was a long procedure, sir. Like,
Okay.
yes, sir.
Okay, okay, okay. Thank you.
Thank you, sir.
Hello, technical team. Hello.
Next presentation technique, please.
Sir.
Good morning, everyone. Myself, Dr. Jainamili. I'll be presenting my paper, Prospective Observational Study of Incidence and Factors Associated with Failed Spinal Anesthesia in Obstetric Patients in Elective and Emergency C-sections. My co-authors are Dr. Monica Bodhi ma'am, Dr. Padmatsu, and Dr. Himyata ma'am. Spinal anesthesia is the most convenient and safe technique to undergo cesarean section. Most effective and many emergency cesarean deliveries are performed under spinal anesthesia. Failed spinal anesthesia is an uncomfortable event both for the mother and the anesthetist, and that may lead to decreased maternal satisfaction and may potentially impact fetal and maternal outcome. Failed spinal anesthesia, it is defined as the partial or incomplete block after 15 to 20 minutes after injection and requiring supplemental anesthesia or conversion to general anesthesia. The primary objective was to determine the incidence of unsuccessful spinal anesthesia in obstetric patients, and the secondary objectives are to determine the factors associated with the failed spinal anesthesia, to determine the first attempt success, that is the identification of the subarachnoid space at the first spinal puncture, and to determine the incidence of conversion to general anesthesia. And it was done in King George Medical University, Lucknow, and it was a prospective study of 640 cases. A prospective institution-based observational study was conducted on 640 participants from January 2020 to January 2021. All participants posted for elective C-sections with a 93.5% hyperbarometric and 25 minutes of methylene was added to it, and it was administered to 29 was quintillated. A structured performer was prepared to know the demographic data, obstetric and anesthetic data, and also inclusion criteria includes participants aged more than 18 years, and both elective and emergency C-sections are included. An ASA rating of 1 to 3. Exclusion criteria: patients not giving consent and contraindication to the spinal anesthesia. Patients undergoing combined spinal epidural. So here are the observations. Characteristics taken for age group, gravida, and parity of the patients, and also the history of failed spinal anesthesia was noted. And the surgical data of the participants, like the type of surgery, whether it was elective or emergency, and previous LSAs, and number of spinal attempts was also noted, and the type of failure, whether it was complete failure and partial or successful block, and the need for conversion or need for sedation. Here's the associated risk factors for a failure of the spinal anesthesia. So in this age group of less than 30, we had 5%, and the other like BMI, gravida, and ASA rating, and history of failed spinal anesthesia was also noted. So in discussion, the study was conducted to determine the incidence and associated factors of failed spinal anesthesia among the participants posted for the C-section. And the result of the study showed that the incidence of the failed spinal anesthesia during C-section was 5.78%. Overall failure rate is above the range targeted by the Royal College of Anesthetists. Studies have reported that the failure actually is widely distributed with a range from 1 to 17%, and a study conducted in South Africa showed a failure rate of 11.7%, while Kinsella reported the incidence of failed spinal anesthesia was 0.8% for elective and 4.9% for emergency. And Ashbury shows a failure rate of 19.5%, which is quite high. In conclusion, spinal anesthesia is a safe, simple, and reliable technique, but failure can occur at any time by any anesthesiologist. Minimizing the failure rate is obviously a prerequisite for gaining the benefits of spinal anesthesia. We conclude the experience of anesthetists was a significant factor for the field of spinal anesthesia, and identifying avoidable cause of inadequate block helps to minimize the incidence of the failure rate. Thank you so much.
Thank you, Dr. Sukhdev. Are you with us?
So, yes, sir, this is Dr. Jharna actually. This
Yeah,
was my
Dr.
presentation.
Jharna. Okay, okay.
Yes, sir.
Yeah, Dr. Jharna from KGMU.
Yes, sir.
Okay, Dr. Jharna. Yeah, it was more or less like a retrospective analysis, right?
Yeah, more of a observational. So I have observed the patients like while putting the spinal anesthesia.
You observe the patients, right?
Yes,
so that is my question to you is that what was the, other than experience of the anesthesiologist, one most important factor you realized in your study that could lead to the failure?
So next I have observed was the positioning, sir. Positioning of the patient, sir. I mean, while putting the block. And next was
positioning. How do the positioning lead to the failure? Failure of doing the procedure may be there, but yes, once the procedure is done, the failure of the block. How the positioning, led to the failure of the block?
It was actually a proper while injecting the drug. Sometimes the patient while putting the drug, injecting the drug,
right?
It was not locked up properly, and then there was some spillage of drug also. That was there, and then after putting the block also, sir, while putting back to like spine position,
There may be a difference in the height of the block, but not the failure. Right? If some amount of drug has gone in or the patient positioning is not supine, it may be head up, head low. So there may be varying degree of height of block, right?
Yes, sir.
But
Yes,
not
sir.
a complete failure.
Yes, sir.
By I hope you mean the complete failure means that the neither the sensory nor the motor, anything is not coming
Yes,
up
sir.
to the patient, right?
Yes, sir. Yes,
So
sir. Yes,
these
sir.
all may be leading to a partial blocks, but not the complete failure, right? Complete
Yes,
failure at times, one is right the experience, the other is due to the drug property also, right?
Yes, sir.
Sometimes the
Yes,
local
sir.
anesthetic, that is more in the clinical practice, we have seen that the local anesthetic batch, specifically some batch, is not at all effective at
Yes,
all,
sir.
right? And the effect
Yes.
doesn't come up, right? So that
Yes,
is
yes.
also. Thank you so much, Dr. Jharna.
Okay, sir. Thank you so much. Funny tha.
The session is over. Check team.
Hello, technical team. Please authentication my share screen. Hello.
Technical team, is the session over? Session of papers over? Technical team.
ये आप ओपन कर दीजिए इसमें हॉल के इमेज
Technical team, does all papers have been done? Miss Priya? Not able to hear you. Okay, so let me conclude the session. Thank you very much, all the delegates, all the participants who have presented. I hope there was some kind of a learning lesson to you people, right? And wishing you all the luck for your future presentations. Thank you.
Thank you, all of you. Dr. Bipin Patel here.
हेलो प्रिया मैम, स्क्रीन शेयर करने का ऑथेंटिकेशन मुझे दे दीजिए। यहाँ डॉक्टर सुखदेव सर हैं, उनका मुझे वीडियो प्ले करना है। हेलो। एक मिनट सर।
जैसे 7 जने हैं प्रेजेंटर, उनके 7 जनों का भी हमारे भी इस वाले उनका प्रेजेंटर कैसे स्कोरिंग पैटर्न इनको भी दिया जाएगा, बिल्कुल दिया जाएगा। अभी अपनी स्कोरिंग अलग करेंगे, अपनी स्कोरिंग अलग करूंगा।
Thanks to Dr. Rasis Diwan, the chairman sandwich.
इसको प्ले करना है। कर दे।
अभी आपको जब नहीं बोलना हो ना
अरे ये कैसे हो सकता है? कितने को
Good morning. I must thank the organizers to share my thoughts about this topic on opioid prescription writing. My special thanks to Dr. Rasis Diwan, the chairman sandwiches, Dr. Tarlika, Doctor. Opioids are essential part of our anesthesia practice.
हेलो
Be it in the theater or pen clinic or palliative clinic, but there is also a myth for
Hello, I am Dr. Tushar Shishar, inviting for the operating room station head hazard, Dr. Sukhdev Nayak, as a opioid prescription and writing. He is a professor of anesthesiology, pain relief and palliative care agency. Yes, sir. Welcome to Dr. Sukhdev Nayak.
कर दिया।
तो हमारे पास वो लिस्ट नहीं है, हमारे पास ना तो लिस्ट है ना अपना नंबरिंग के लिए कोई भी नहीं है।
Good morning. I must thank the organizers to allow me to share my thoughts about this topic on opioid prescription writing. My special thanks to Dr. Rasis Diwan, the chairman sandwiches, Dr. Tarlika, Doctor. Opioids are essential part of our anesthesia practice, be it in the theater or pain clinic or palliative clinic. But there is also a myth for opioids. We are really afraid because of the rules associated with the prescription for opioids. I will try to dispel most of the most of the thoughts lingering in the minds of the doctors who are going to practice opioid therapy. I'll give some time to the Narcotic Drugs and Psychotropic Substance Act, because it is much related. The prescription, the availability, everything depends upon these drugs, and most of our doctors are not aware of the background. So I'll give few minutes there about how it happened, how the rules were modified. So few slides on that. Because of a lot of unlawful activities and lot of diversion in the Western border of our country, and which also the morphine manufacturing states, that is Rajasthan, the opium belt, Rajasthan, UP and Madhya Pradesh. So the government was very much worried about the unlawful and illegal use of these narcotic drugs. So they came up in 1985, the NDPS Act, Narcotic Drugs and Psychotropic Substance Act. And it had got very draconian rules and tough punishments because the government was really worried about the illegal use of morphines. There was very severe illegal diversions, opioid belt in Rajasthan, MP and UP, and the morphine consumption was so drastically affected because of the rules. From 200 kgs, it became very few kgs only per annum. Using oral morphine or other narcotics, they really worried because the drugs are simply not available. So here I saw the NDPS Act came in 1985. It was modified twice because of the severe demand among the doctors to make available, and the draconian punishments were to be repealed. The rules are so much confusing, and each state had got different rules. So if you get a permit from one state, if you apply for the drugs to arrive from the other state, by the time you get the permit, the drug, the other state has the permit has expired. So these have got really very big problem. So, and the manufacturers and the end users are in all different states of India. So actually, this NDPS Act of 1985 was a Pandora box of confusions. These two modifications in 2001 and major modification in 2014 dispel these rules. Why there was a need for NDPS Act? Because morphine is and it's unique in its analgesic property. A patient has got a panacea for morphine. Many patients are really relieved by oral morphine. Government has the dual role of controlling the illegal use and supporting the medical use of and improve access for research purposes. So it has to actively prevent the misuse, and you should make it available for scientific use. The other point is that in the manufacture of the drugs, limited number of states. So other states, all the states are using. So we have to have a uniform rule so that drugs can be available throughout India. All this made the government to go for amendment, and the amendment came in 2014 and the rules came in 2015. Actually, what are the major amendments? It expanded the scope of the medical and scientific use. It gave lot of importance. Previously, it was giving lot of prevention of illegal use. Here, it gave importance to the medical and scientific use. And for the first time, it had elaborated the 6 essential narcotic drugs, or which are really needed for most of our pen and practice. These are the and these essential narcotic drugs are controlled are notified by the Drugs Controller General of India, and these includes morphine, methadone, codeine, hydrocodone, oxycodone, fentanyl. However, oxycodone and hydrocodone are still not available. However, all the other 4 drugs are plentifully available, and these essential narcotic drugs are at the purview of the central government, which can modify as per the needs, as per the scientific research comes. Then it came with another provision of recognized medical institutes or RMIs, which can stock and dispense morphine for the patients. So, what are the recognized medical institutes? All institutes, they conferred that medical institutes can be authorized, and it could be authorized by the state drug control or the drug commissioner or the food and drug administrator of each state will recognize the institutions, and the institutions fulfilling the criteria by the government, they may apply to the above authorities to procure and dispense essential narco drugs. And unlike the previous act, it too is valid for 3 years, so there's no need to renew every year. And there is a need to obtain license from the procuring state as well as the using state. This is dispensed. Medical institute they are allowed by the drug controller to stock and dispense the essential narco drugs. And for the first time, all government hospitals are automatically designated RMIs provided they have the facilities. And the private hospitals are open to apply to the state drug controller, who can examine their case by case and permit them to be RMIs. And for the first time, RMIs can directly contact without any permits to the manufacturer or suppliers, and the drug can straight receive from the factories of a supplier to the end users in the hospital. So the end of permit runs. What are the requisites for medical institutions? It leads the training of competency of the end users. Any institution defined above can purchase, store, and dispense morphine. The institution must have an officer in charge of E&D. He is in charge of the narcotic drugs in that RMI, and is responsible for the managing all the stock, records, and dispensing of the drugs. The officer in charge is a qualified doctor registered with an MCI or now National Medical Council, or he may be a dentist registered with the Dental Council of India, and he is specially trained in use of medical opioids. That is a special training. The institutions must have the facility for a proper storage of essential narco drugs. There should be a double locking, one with the pharmacist, one with the doctor, and there should be always 2 locks, so that whatever drug is dispensed is properly recorded. And the hospital should have a basic infrastructure for staff and evaluating and managing the treatment of patients who need the essential narco drugs. And the hospital should have provided space for stocking and proper record keeping, and personals should be properly designated to handle that particular job. And how to improve opiate? There is a morphine myth that many of our doctor friends, they think morphine causes respiratory depression. That's why many times they delay the start of oral dose of morphine, because they think respiratory depression, if they give oral morphine will cause respiratory depression, and the patient may hasten death. But actually it has been proved scientifically that if there is a pain, it is a respiratory stimulant. Pain causes tachypnea, and the respiration rate of about 40 in a severe pain of a patient, if we give morphine, that tachypnea of 40 may come down to 20 or 15 or 18. So it becomes from tachypneic, it becomes normopneic. So that ghost sitting in our mind from our physiology class of first MBBS, that morphine causes respiratory depression. It causes respiratory depression in a normal human being, not on a patient suffering from pain. So we should always try to understand, and always you should start with a very low dose, but we should go slowly to increase the dose as in when the patient's pain is not controlled the particular dose, and then do so continuously, as my teacher Robert Tycros from Oxford has been telling. Start low, go slow, and do so. We should always prescribe the oral morphine at the lowest dose, but very effective dose. And we must always reassess the individual benefits and risk. And whenever we are increasing the morphine by 50 morphine milligram equivalents per day, then we should be really cautious and we should always check and balance. But whenever we are using morphine milligram equivalent of more than 90 per day, we should really justify ourselves that does the patient real need to increase the oral morphine doses. There is a word of caution. Opioids are very nice drugs, but there is always a risk of overdoses. So, and the risk is always involved. So we must always think that whenever we are giving, we must always think about the risk involved. Risk can be estimated, but modifications are really needed and the patient comes regularly. So whenever we are starting the dose, we should frequently reassess the patient, and when the patient is already established, we should also do reassessment. And there are 10 essential steps for opioid prescription. This, if you follow these 10 steps, this will really help to mitigate any potential problem in the future. The first is diagnose with proper differential diagnosis of other causes of the pain. Second is the psychological assessment, including the risk of potential drug abuse. We must do a proper psychological assessment of the patient, his behavior. Maybe we may need a real full-time psychiatrist about the starting of oral the narcotic doses. And we should have informed consent from the patient and the families about the treatment and consent about the treatment. We should always assessment of the pain level and functionality, what is happening to his daily activities. And we should always appropriate trial of opiate therapy with or without adjunct medications. We must always see that there is always adjunct medications like nerve blocks, yoga medications, other medications, meditation and spiritual therapies, and more important is the IUs, the alternative medicine recommended by Government of India. So actually there have been several publications that all these blogs, yoga, meditation, all these things actually reduce the dose of the narcotics that we use, opiates, and really the dose of opiates comes down if there is a parallel treatment with all these drugs. And we must always reassess the patient's level of pain and other functionalities. And regular assessment with the 5 A's, that is analgesia, activity, adverse effects, aberrant behaviors, and affect, that is pain, mood. This is at every visit of the patient. Definitely you can diagnose and detect any aberrant behavior, any possible change in drug addiction or any dependency, and we can prevent that particular patient from going astray. We should always review periodically the diagnosis and comorbid conditions, including substance use disorders. And the last, but not the least, documentation. We must document the doses, the side effects, the other behavioral issues, the 5 A's, all these things. If you document well, this will save the patient and the family as well as the doctor, because if you do proper documentation, everything will be detected at an early stage and everything can be prevented. Assessment, reassessment is very, very important. We must see if there is a change in the pain origin of the site, health and the function of the patients, and you should always take input from the family members, and there should be proper patient contact during the initial stages as well as when we change the doses or we change the narcotic drugs. Patient contact should be increased in these two stages, and decisions regarding continuations, modifications or termination of any opioid therapy of pain should also be based on evaluation of the patient's progress and absence of any substantial risks or adverse events and input from the family. So when we assess and reassess the patient, again there are 5 A's, and if we stick to those 5 A's, it will help us the chronic pain patients much problems in the long run. This is what is the type and quality of anesthesia, what is the affect, that means the patient mood when he's taking these drugs. If there is any change in mood, the family will always, especially the wife will always report there is change in the mood when they take the drugs. So that is an important key for us to reassess. And activities of daily living, whether he is able to do his own daily living activities of taking care and the toilets, everything he's doing, or he's dependent, that also gives an input about our continuation. Adverse or side effects are also be detected at the during the assessment, and any aberrant drug-related behavior should also be looked into during this reassessment. All these things will really help us to assess and properly progress with the pain treatment. Now, at the last, I must give the official opioid prescription format that is recommended by the new amendment. The prescription should have the name, age, sex, and address. Now, this new amendment says that we should have a mobile number of the patient recorded on the prescription, so that whenever there is any reassessment, any follow-up is required, the hospital can contact the patient with the mobile number. And the prescription, second thing is the element, the disease or the condition for which we are going to prescribe oral morphine, and the drug name, exact name of the drug, and then the dosage and the direction for the patient's use, whether it is 4 hourly or 12 hourly, or if it is a continuous release, it will be 12 hours. All this has to be given written in the prescription, and we have to write the quantity, that is how many days we are prescribing the drug. Sometimes we prescribe normally it's for 15 days, but normally if the patient is coming from a very distant place, the doctor can prescribe and take a liberty of give for a month's stock to the patient. And lastly, the practitioner's full name, his registration number, address of the hospital, and signature with the seal is very, very important. So this is the official prescription format for narcotic drugs. These are my relevant links, and if anybody is interested, they can contact me. I can help them for the proper procurement of any guidance or any help. With this, I conclude my topic, and I bring greetings of my colleagues from AIIMS Bhubaneswar. Thank you. Namaste.
Tonight's lecture given by Sukadev Nayak, sir. Hello. Hello. Now, really, it is very helpful to each and every practitioner, and to the narcotic. I am inviting Mr. Chandrasekhar Kerna for the pre-operative assessment as a role of anesthesiologist. Thank you. Welcome.
Hi. Good morning, everybody. First of all, I thank the organizer for giving me the opportunity to present my work in this conference. My topic for today is pre-operative treatment and optimization and anesthetist domain. The choice is, it was in the year 1988 when I started this practice. There was using of culture. We used to administer the Clarican and Campus bag or Belos. There were no poison. There was no oxygen or oxygen cylinders available. Investigations were very limited. Hemoglobin, urine, and sometimes blood sugar, blood urine. Peripheral setups were horrible, and the following were the monitoring standards. Only a hand on pulse, continuous. Color of the blood, which we used to observe closely. There were no pulse oximeters. The surgeon also used to inform by chance if the blood becomes blue, he used to alert. Then close observation on the respiration rate and depth, hydration of the tissue. Then there was a close watch. There were no intracats. Sometimes these skull insects used to go out, they used to be swelling, and then there used to be a lot of confusion. IV infusions used to get glass bottles during those times. If a patient goes into hypertension, it was impossible to push the fluids like that of today. So what we used to do, we used to put a ether bolus in the glass bottles, and the infusion used to run fast. But then you have to watch it very closely to prevent any embolism. So it was in 1988 when we received a 70-year-old woman with uterine prolapse at a peripheral setup. She was posted for vaginal hysterectomy. It was my just second visit in my private practice. She was a grand multiple. There was dyspnea on exertion. There was history of bronchial asthma. She was hypertensive. On examination, vitals were normal, but there was bronchospasm. The general practitioner had given her steroids and bronchodilators before we arrived, but still I could pick up some bronchospasm on auscultation. Fortunately, we had a visiting physician with us, and we advised to give an ECG recording for us. ECG was showing gross global ischemia. There was ST depression, T wave inversion on the lips. But the physician was very confident. He told me, go ahead, give spinal, and nothing will happen. But my opinion was different. I had different ideas. I was of the opinion that this patient should be put on coronary vasodilators and bronchodilators and should be posted during our next visit under epidural anesthesia, which was not popular in those days. So I was able to convince the general practitioner who had posted the case, and collectively we decided to postpone the case. Since I was a very junior anesthetist, the gynecologist decided to shift the patient to nursing and call his regular colleague. One of my senior colleague administered spinal, and she suffered a cardiac arrest on table immediately. Details of this episode were not available. I came to know only 15 days later. We had gone for the next visit. Fortunately, she was revived. She was critical for 48 hours and got settled. The general practitioner thanked me from the bottom of his heart during my visit. So the decision of going against the physician's opinion proved right at the right time. So the choice is yours, whether to go ahead or not. We come to the second case. It was again 1980. I was a full-timer in a private institute in Nasik, and we received a female, 30 years old, came with breathlessness, palpitations. She had bleeding piles. She was grossly pale. Hemoglobin was 2.5, but she was not in failure. Other investigations were normal. Heart rate was 128 per minute. BP in upper extremity was 150 by 100 millimeters of mercury, but there was no pulse in the inferior extremity. It was not felt. Femoral was not felt. Dorsalis pedis was not felt. So something was suspicious. Then we ordered for an X-ray chest. It was showing gross rib notching. So this was a full-fledged case of coarctation of aorta. ECG was showing ST depression and flattened T in anterior chest leads. Echocardiography in those days was not available in private setup. So I had a word with a visiting cardiologist. He advised me not to touch in anticipation of mortality on table. The surgeon was informed accordingly, But I also conveyed him that, sir, I can handle this. And we all agreed to go ahead. So counseling of the patient, counseling of the relatives was done. They were ready because otherwise she would have bled to death gradually. So a high risk informed consent was taken. IV line was secured. Sphygmomanometer was attached. ECG monitor was attached. Fortunately, it was available during those days. In the sitting position, she was given oxygen through a mask. A saddle block with 5% lidocaine, 0.8 ml, using 23 gauge autoclave spinal needle was given. In those days, we never had disposable needles. We used to be happy with the autoclave steel needles. Sitting posture was maintained for next 10 minutes, and she was then made supine. Hemorrhagectomy was successfully done by the surgeon. Surgery, anesthesia, both were uneventful. Blood transfusions were given subsequently. She was discharged on the 5th day. So the decision to go ahead, in spite of the cardiologist saying no to this patient, it proved right. So the choice is yours. Again, it come to the third case. In 1997, again I was in a private institute. We had a 30-year-old engineer who met with road traffic accident. He had fractured humerus on the left side, for which he was posted for surgery. There was no significant past history. All investigations, including ECG, were normal immediately on admission. Humerus plating was planned on the 4th day. On the 3rd day, I had taken my preoperative round and saw this patient in detail. The history was noted. Patient was absolutely comfortable in bed. There was no head injury. On inquiry, he gave me the history of blunt injury on the left side of the chest involving 3rd, 4th, 5th ribs and intercostal spaces. Vital parameters were normal in the case paper, as written in the case paper. Pulse was 90 per minute. Full 1 minute pulse was counted, and which was showing 4 to 5 missed beats per minute. So something was suspicious, definitely. Then I saw the physician's remark on the case paper. He had mentioned fit for anesthesia. Fresh ECG was ordered along with long lead. 2D echocardiography, unfortunately, was again not available. ECG was showing gross ST elevations in all the limbs. Premature ventricular contractions were seen. On deep inquiry, now the patient started giving me the history of occasional palpitations. So a diagnosis of myocardial confusion, or in a scientific term, we call it as contusio cordis, was made. The case was postponed, referred back to the same physician. So the decision of not to go ahead was justified in spite of the physician's fitness. So how was this patient managed? The cardiac enzymes were raised, which were sent immediately. He was treated as a case of acute myocardial infarction. Then he was sent for cardiological evaluation in the city to a private cardiologist, the only cardiologist during that time. 2D echo was done. There were no injuries to the valves, no injuries to the papillary muscles and posterior wall. He had put the patients on antiarrhythmics and coronary vasodilators, and this infarct and this injury got settled within a week and was operated for cervical epidural anesthesia. The anesthesia surgery both were uneventful. Post-op epidural analgesia was offered, which was quite effective. What are the advantages of cervical epidural anesthesia in this case? First of all, coronary vasodilatation after load reduction, then favorable oxygen supplies to demand ratio, bradycardia, which is beneficial in this particular type of cases, improved cardiac index, reduction in infarct size, effective pain control, and decreased chances of post-operative ischemia. So the choice is yours. So under cervical epidural anesthesia, this patient did very well and he was discharged subsequently. Post-op absolutely uneventful. So now we come to 2005 almost. In 2000, 2001, Nasik was fortunate enough to get a cardiac setup. And in this particular case, it came to us in 2005. She was a 25-year-old female presented with severe stridor, gasping. She was cyanosed. There was past history of road traffic accident 8 months back. There was history of head injury, chest injury during that time. Details were not available, but she was on a ventilator for almost 20-25 days, out of which she had recovered fully. Now she had landed in a private hospital, developed progressive breathlessness. There was cough with expectoration off and on. Gradually developed a severe tracheal structure, 1.5 millimeter just above the sternal notch. Now she developed stridor. She was in cerebral encephalopathy because of CO2 retention. There was tachycardia, tachypnea. She was disoriented. Bronchoscopy was attempted in private by an ENT oncosurgeon, but the stridor aggravated because of the handling. There was severe laryngospasm. He immediately called me. He was my friend. He immediately called me, and he decided to shift this patient in our cardiac setup. Our CVTA team was ready. There was absolutely no time for investigations. When she arrived in OT, she had severe cyanosis. She was semi-conscious. She was disoriented, rowdy, and her gynecologist uncle, who was with her, he went on back foot and he said, let us not do anything. Let her die peacefully. But we convinced him that give me a chance. Definitely, we'll try something for her. So ultimately, he gave permission. A special consent was taken. When we received, she was the pulse rate was 160 per minute. BP was 80/40. SpO2 was 45. Oxygen was given by mask 8 liters per minute. Injection ketamine 100 milligram was given intravenously. And when she was anesthetized, femoral artery and femoral vein were cannulated. Local infiltration was also given. After cannulation, injection heparin 3 milligram per kilogram was given to achieve an ACT of more than 360 seconds. A femoral bypass was established. Injection atracurium 50 milligram, injection fentanyl 100 mics, injection midas 5 milligram were given on the palm. Cyanosis vanished immediately. She was adequately relaxed. The parameters gradually set. Trachea was dilated by the ENT surgeon or the ENT oncosurgeon with Hagar's dilators, and a tracheostomy was performed number 8 tube, which the surgeon was able to manage. Now the APGs was showing severe acidosis. The acidosis was corrected on palm. Gradually, after the dilatation, when everything was over, she was weaned off from the cardiopulmonary bypass. Heparin was reversed with injection protamine in a ratio of 1:1. Now the pulse was 90 per minute. The blood pressure was 110/70. SpO2 improved to 100%. EtCO2 now was 30. ABGs were normal. Then we shifted her to cardiac ICU. She was electively ventilated overnight and extubated on the next morning. Discharged on the third day, alive, awake, and absolutely alert. So the decision to go ahead was right, in spite of the relatives or the gynecologist was reluctant to go ahead with this case. So the choice is yours. What is the monitors? Following things are monitored: invasive blood pressure, NIBP, temperature, pulse oximetry, EtCO2, urine output, intermittent blood gases. So that is the take-home message: to be or not to be, the enter choice is yours. Be absolutely firm on your decisions. Physicians, cardiologists, endocrinologists can offer us valuable help, but the anesthetist decision should be final. Don't get influenced by the seniority of the surgeon and or the physician. The well-being of the needy patient is more important ultimately. So thank you very much for your patient listening, and thanks for the opportunity.
Yes, sir. Very nice lecture for the preoperative assessment. And we are thankful to you, Chandra.
Yeah, thank you, sir. Thank you very much for giving me the opportunity.
Welcome to Shiv Kumar. Welcome, Shiv Kumar. Go ahead. Welcome, sir. He is a professor and consultant anesthesiologist and medically advise the pain and palliative care.
I have one query in mind.
He has done MBBS from the Kulbar, DA from the Karnataka Hubli, and MBA Hospital Administration. Now,
muscle relaxants do not provide analgesia.
welcome,
How
sir.
can you compare
Go ahead with your
analgesic effect
lecture.
with the muscle relaxant?
Hello. Hello. So some problem in the connection. I am welcoming to the Shiv Kumar. Hello. Hello. Hello? Hello?
One minute, 1 minute. When you are speaking, then your slide should be, you should also see what you are speaking.
And you should be.
Yes, yes, sir. Thank you. I'm welcoming Shiv Kumar Kumbar. He is a professor and consultant and medical legal advisor, pain and palliative care therapist. He is MBBS from the Gulbarga, BA from the Hubli, LL from the Dharwad, LLM from the Simoko, and he is also MBA hospital administrator. He was vice president in Karnataka in 1617, vice president in Karnataka state 19, and he is a standing committee member of the IM headquarters. Please go ahead. Welcome to the Shiv Kumar Kumbar.
Hello.
Yes, sir. Welcome. Welcome, sir.
Yeah, can you hear me?
Yes, sir. Yes, sir. Yes.
Yeah. This is Dr. Shiv Kumar. Thank you, organizers, for giving me an opportunity. Yeah. Okay. And it's an unprecedented experience arising from the potential tissue damage are described in terms of such damage. Always you have to see to that the pain itself is a subjective. Okay, and that it is most of the times. So freedom from pain has now emerged as a fundamental human right. There's so many declarations world over. Next slide, please. Yeah. Before we proceed to that, we should know some ethical values. Okay, failing to provide a patient with basic right of comfort. Okay, while in a severe distress is a breach of human right, I would say. In the meantime, there's a lot of controversies, and I would say that they
If you are requiring more analytic
Hello.
post-operatively,
I
these your
think
blocks are not
we are
sufficient.
getting some problem
If you are giving the
from
paracetamol
the
post-operatively, I agree. If it's the established technique, you can provide this. But how will you compare? If you could have avoided the paracetamol, then we could have come to conclusion that
Hello.
rank of FCN can be a complete analgesia post-operative.
I'm welcoming the Vasant Kumara.
Dr. Surbi, one short question.
He is a lifetime hearing achievement. Yes, sir. Welcome.
Good morning, friends.
Yes,
I am
sir.
Dr. Vasant Kumar, Professor of Anesthesiology from Adi Chunchanagiri Institute of Medical Sciences, Bijinagar, Karnataka. I would like to thank the organizers and scientific committee for giving me an opportunity. Today I am going to talk on anesthesia stress and balancing with spirituality. See, spirituality is so much important in our life, but due to the materialistic world, we are all forgetting the spirituality and spiritualism. We are all born spiritual human beings, but we are caught into the materialistic world and forgetting the spirituality which is built in every living beings. And first of all, I would like to show you a slide which credit should go to Dr. Ganesh Chaudhary, the evolution of anesthesiologist in allopathy. It's a wonderful slide. He had made it. I took it from him. And what is happening in the present day is we see a lot of well-educated but mentally abnormal population. We are all very well-dressed but heavily stressed. We don't need such mentally abnormal population, especially well-educated mentally abnormal population in present society, because it is going to affect a lot of economic to the country's development and also to the human beings and also to the economy of any country. Especially America is spending $3 trillion per year just to treat the illness. Just imagine how much of stress it has got, financial stress and social stress on the government. Why most of the educated especially the professionals get into the stress is because of their monotonous lifestyle and physical stagnation and professional stagnation. Same thing applies to the medical fraternity also, and including the students, postgraduates, residents, and also for the consultants. What is happening is the stress is causing so much. Looking at pathetic pathologists, nervous pathologists, heartless cardiologists, and AMS anesthesiologists. We are producing more and more such people in the society, which is not good for the medical fraternity or even for the care of the patient. And we'll come back to the anesthesiologist. Anesthesiologists are, the role of the anesthesiologist is multidimensional, especially after the breakout of this pandemic. We have to look after the operation room and COVID operation theater, intensive care unit, pain management, and so many other fields, as we all know, in emergency and other things. And because of these things, multi-dimensional role, we have to deal with the multi-dimensional people with the multi-dimensional factors like their emotions, their mental stability, and their physical problems, along with the patients. That's why anesthesiologist needs more compared to any other professionals, needs more physical strength, mental stamina, and more emotional stability. Otherwise, usually we get into the stress and affects our professional performances. And especially anesthesiologists, because of the multidimensional role, they burn out physically, mentally, and emotionally, and they get exhausted, and they become emotional instability and ineffectiveness over a period, and unhappiness and dissatisfaction at work. And most important is low remuneration also causes the stress for the anesthesiologist, and there will be, most of the times, there will be no recognition and appreciation. And in spite of their lot of efforts to save the patient or to overcome the tough situations, that is causing the lot of stress, putting their lot of stress on them, and it is causing burnout syndrome that may lead to their personal problems, marital problem, emotional disorder, decreased empathy, and psychological withdrawal from work. And to cope up with the stressful life of anesthesiologist, due to overwork and easier access to drugs, what they do is sometimes they start consuming the drugs. That becomes a very big problem. This is, some of the studies shows that the anesthesiologists are 3 times higher than other professionals in consuming the drugs. And UK study shows 46% of the residents are losing their precious academic year because of the drug addiction and stressful life. And substance abuse is increasing worldwide, even in professional, because of because of easy availability of the drugs. And especially in anesthesiologist, incidence is 2.7% more when compared to others. And also death among substance abusing anesthesiologists is much, much higher when compared to normal anesthesiologist. Why usually anesthesiologists get into the stress is they always start expecting something, or any human being, including anesthesiologists, they start expecting something in their working place, and they want to prove they are better than other people. And sometimes they go through the roughest patch in their life or even in the working place, and they try to get too much of information and too much of knowledge, and they give a lot of importance for some people. Materialistic people will give a lot of importance for lifestyle and number of cases, that is a quantity of cases. Instead of that, if they, instead of expecting, if they start accepting things, and instead of proving, if they start improving, instead of go through, if they grow through, and instead of collecting a lot of information and knowledge, if they start transforming themselves, and instead of lifestyle, if they give importance for their life, and instead of quantity, that means number of cases, number of properties or something, if they give importance to their quality of life, they can come out of the stress and they can enjoy their life. And not only the stress affects their ability to concentrate, and also the treatment aspect, it also affects the integrity, humanity, humility, flexibility, and even the emotional stability. These are all reflects in the operation room or working place, and also it affects other subordinates or postgraduates or nursing staffs and OT staffs. And when we are under stress, we will be usually unhappy. And when you ask somebody, or whether it is anesthesiologist or any specialist, if they are consciously, if they want to be unhappy, nobody says yes, because everybody wants to be happy. When they are consciously, they want to be happy. And if they are unhappy, that means they are really working unconsciously. Because why we are working unconsciously and becoming unhappy? Because always we outsource our happiness, which we don't have any control on that. Instead of that, we can always insource the happiness. That means that happiness must be from inside, then nobody can affect it, which we have 100% control. Whereas when we outsource it, we don't have any control on the external factors. And also the happiness affects by invisible infections of the mind, like stress, anger, frustration, hatredness, emotions. These are all contagious. When senior anesthesiologists suffer from the stress, anger, frustration, hatred, emotions, it spreads to juniors, residents, even in the operation room, along with the surgeons, patients, everywhere, and outcome will be a very bad thing. How to overcome the stress? It is, see, these 3 steps we have to follow in our life to overcome the stress in the working place by anesthesiologist. We should start accepting the things as it is, and we should start accepting the people as they are, and we should start accepting the situation as it comes. These are the main 3 factors. If we adopt in our life, we can overcome the stress. But do you think, is it easy? Is it so easy to adopt these things? It is very difficult, because it is very difficult to sustain what is seen, that is success, health, a good relationship, happiness, other things, when we don't work on what is unseen, which is spirituality. Very, very, very important. See, when you have become spiritual, automatically your happiness, good relationships, everything starts improving. That is what is unseen. We have to give more importance to the unseen to maintain or sustain the what is seen. That's why spirituality in Sanskrit, it is called as Adhyatma. When you give first preference to the Atma, that is Pahala Adhyata given to the Atma is called as Adhyatma. When you start giving importance to the Adhyatma, Atma, then automatically everything falls in line. See, life is incomplete in the absence of spirituality. Hope, belief, self-awareness, compassion, sympathy, and empathy, these are all the factors of spirituality, spiritualism. By ignoring the spirituality in the modern day medicine, even though it has developed so much with the modern day technology and other things, still it is incomplete because it is forgetting the spirituality. Nowadays, a lot of people importance are given to the spirituality, because by ignoring the spirituality, we are ignoring the significance dimension of life of a professional, as well as the patient, as well as the society. Because there are no materialistic solution to spiritualism, but there are spiritualistic solutions to almost all the materialistic world. You can get it. So when you become spiritual, the difference between materialistic and the spirituality is, when you are materialistic, your mind is full. That is 2 words. Lot of things, that is a car, external success, money, bank balance, dress, everything, and hatredness, anger, everything will be filled with mind. That becomes a mind is full. Whereas when you become the spiritual, it becomes 1 word, it is a mindful. Then you will be in the present, you will live in the present, and your perceptual life experiences changes, and you become happy, and you can enjoy the moment. And when you become a very spiritual, you start loving yourself to the maximum and start taking care of yourself first, because you are the most important person in your life when compared to others. When you start loving yourself to the maximum, then your Atma or your mind does not seek appreciation from others. That's why always I say, taking care of self is not selfish. It is taking care of only myself is more selfish. That's why we have to take care of self, and we have to start loving ourselves first when compared to others. Then we can do a lot of good things, and we can come out of the stress and do good things to the society. And we have to be easy inside and be busy outside. Otherwise, or even if from inside also, if we become very busy, we get into the stress and our performance starts coming down, and our fascination gets into the frustration. Instead of frustration, converting frustration into the fascination. When you become spiritual, you can convert your frustration into fascination. That is more important. How to achieve it? Start doing small things like develop your passion. You should give importance to the passion so that it is a greatest stress buster. That is drawing, music, dance, drama, or something you should do. Everybody is born with some passion. We have to give importance to that. By doing this, you can have a correction, communication, flexibility, all these characters, you can develop it. And also you start celebrating the success, whether it is accomplishments, whether it is even if it is a very small block you have given, it has become a successful. Even if it is the 100th time you are giving it and become successful, you start celebrating that success, accomplishment. And always you try to recognize, appreciate the juniors when they do it something good, when they do something, really achieve something. We have to recognize them, we have to appreciate them, because always we expect something, same thing we should give it to the others. And always we should develop 5 F's to have a very good relationship inside the operation room and to come out of the stress or working place. We should be fair in our character, we should firm in our character, we should be frank in our character, we should be flexible in our character, and we should be friendly with everyone unless something is there. And especially with the junior colleagues and postgraduates and residents, we should soften their weakness and bring their virtues to the light, so that the good atmosphere develops, good relationship develops among the professionals. And you should be always ready to take decision, and you should be ready to face the consequences. Another thing I always observe is what happens is most of the junior anesthesiologists, when they are doing post-graduation or residentship, when they get some problem with the surgeons, that is why I take an example from Mahabharata. When they behave like they become Draupadi in front of the surgeons, Duryodhana and Dushasanas, then usually what happens is most of the senior anesthesiologists, they sit like Bhishma, Drona, Krupacharya, Pandavas. They don't support the junior anesthesiologists, which makes a very big scar in their mind and emotion, which carries when they become the seniors, and it becomes reflects in their day-to-day life. Instead of that, all the senior anesthesiologists must be behave like Krishna, and they should support the juniors. And when there is a problem, they try to solve the problem and find the solution and make it a Rangabhumi working place. If not possible and condition becomes worse, then should be able to support the juniors, and also they should be able to make it Ranabhumi. And other character we should learn from Rama. Sri Rama is anesthesiologist can learn a lot of things from Sri Rama. They should be a great warrior, medical warriors. They never hate anyone, and they should train the local tribes. That means the whatever fresh postgraduate residents you get it, we should train them, and we should have sympathy for their people and empathy for the patients. And we should recognize even the service of the lowest, even the last person who works along with us, whether it is in ICU, pain clinic, or even in operation rooms. And we should give the precise role for those people depending on their characters and emotional. We should be emotionally balanced. And also we can learn very good thing from Shiva. This picture if you see in the Kailasa, where a lot of prey and predators are there, but still there is no fear, anger, or hatredness you can see among the animals or living beings. Because when there is a wisdom of Ganga flows from the head of the institution or senior inside the working place, and crescent moon like smile on the face, then it works like it becomes working place becomes like Kailasa. In spite of, irrespective of our deficiencies and difficulties, you can have a very peaceful and lovely atmosphere in the working place, stress-free life. How to achieve it? Start doing yoga every day for 10 to 15 minutes and yogic breathing. You can have a control on the mind, and it has got a lot of other advantages. And also start doing meditation, which produces neuropeptides, oxytocin, serotonin, dopamine, endorphin, insulin, and also produces anandamide, which gets you to the ecstasy, so that you will be always happy. You will never depend on external factor because you are happy from inside. And meditation is so important. You can see even the greatest gods, Bhagavans, are doing meditation. And when you become spiritual, instead of when you are in a materialistic world, you will go through the life. Whereas if you become spiritual, you will grow through the life. That is the difference between materialistic world and spiritual world. When you grow through the life, it will not only add years to life, it also adds life to years. From Atma to you can become Paramatma or Mahatma. From caterpillar to you can become butterfly in your life. And always I say, it is allopathy, homeopathy, or naturopathy. Does not matter. What matters is sympathy and empathy when we treat the patient. Allopathy, homeopathy, naturopathy, sympathy, and empathy does not matter. What matter is, if it does not work, it is better to go to Tirupati and pray Lord Venkatachalapati. That means we have to be spiritual to be always happy, healthy, and do the service to the society. Thank you. Thank you, one and all. Thank you. Once again, I thank the organizers for giving me an opportunity. Thank you.
Excellent lecture given by the Vasant Mahatma. Yeah. Not only the practice and material person, but being a spiritually, really it is very helpful to all the anesthesiologists and common men too. Very nice lecture by Vasant Kumara Mahatma. Thank you very much. Anu, agak di barne 23 થાય છે એટલે
Dining area, sir.
How? You did not allow, but how? How you manage?
Good day to all. Today we are here to discuss about the pre-hospital setting of trauma care in our country. And across the country, we have participants, faculty, who are going to give inputs on how trauma care is progressing and how trauma care can be effectively changed, what are the gaps that we have identified, and what we can do to improve the trauma care services. I am Dr. Aruna Ramesh. I head the Department of Emergency Medicine in Ramayana College, Bangalore. My area of interest is trauma and emergency care. So I'm going to introduce today's participants. Dr. Balwinder Kaur Rekhi. She is a professor of Department of Anesthesia, Patiala, and she has got various national and international publications. She has got a vast experience and has got great interest in trauma care. We have Dr. Jitinder Kaur, who is also a professor in the Department of Anesthesia, JIPMA, Chandigarh, and she also is highly interested in improving the trauma care services and critical care services. So she contributes a lot, not only in writing chapters in books, but also in highly indexed journals. Then we have Kaushik, who comes from Kerala, Ernakulam, and he is a consultant neuroanesthetist and a neurocritical care physician. So his area too is in trauma. He looks forward to contributing for improvement of trauma care and assisting in ensuring patients are taken care of in the situation with head injury when they land up in his hospital or across the country. Dr. Jyotsna Agarwal is an associate professor of anesthesia, and she comes from Delhi. She has got a lot of experience in not only providing general anesthesia, pain management, but especially in quality and patient safety. So she is here today because of her interest in trauma care. So friends, road accidents are occurring every day. WHO has said that there are 9 deaths occurring every minute across the world. So as we talk, there is 1 death happening on the road. And with every death, there are at least 7 to 8 persons injured. So we have to ensure that the appropriate care is delivered to these patients or victims, not only at the site of accident, but en route to the hospital and also at the hospital. So today we are going to be having a panel discussion to look at the current state of pre-hospital care. What are the gaps that has been identified and how we can actually contributing to improve trauma care in the pre-hospital. So let us start the panel discussion. So going to Dr. Jitender, can you say on what are the components that actually are a part of pre-hospital trauma care?
Well, at the onset, thank you, ma'am, for your kind words of introduction. Well, the pre-hospital trauma care consists of a bystander who is, who is the witness to the trauma, to the accident happening, and he is usually the first person who comes in contact with the victim. So it's the bystander. Then call for help is the next very important component. And before they call for help, I think another important component is that they need to ensure the road safety. Call for help, ambulance, and then taking the patient to the hospital. So these are the important components of pre-hospital care.
Excellent. That's you have put it very well across. Now, these bystanders who are going to be there who have witnessed the accident or are available next to the victim. So who do you think are going to be these bystanders?
Ma'am, the bystanders it all depends upon where the accident is happening. So if it is in the city, and it all depends upon the time of the day it is happening. So if it is in the city in the morning, it can be, house helpers, it can be people who are going to their offices, or it can be policemen who is standing at the traffic signals. And when it goes to on the highways, they are usually the shopkeepers who are manning their shops on the highways, or they can be truck drivers, vehicular drivers, or other passengers if in case the accident has happened on a public transport vehicle. So they are the common bystanders.
That's true. I am sure Dr. Jyotsna, Dr. Kaushik must have witnessed accidents on their way to work. Have you, Dr. Jyotsna?
Yes, ma'am.
Yes.
Yes, ma'am.
Dr. Karthik? Sorry, Dr. Kaushik. Yes, please. Sorry.
I have also witnessed many accidents on my way to work, and sometimes when I went for long trips on national highways.
So, Dr. Jitender, what do you say that should be the skill sets of these bystanders who are there who witnessed the accident, are ready to help. What skill set should they have? Dr. Jitendra.
Ma'am, there was probably a disconnection. Can you say the question again?
Yeah. What are the skill sets these bystanders should have to help the victim?
Well, ma'am, the very important component of skill sets that they need to have is, first they need to ensure that the road safety is there. So they need to learn what is road safety. So whenever accident happens, they should be able to understand that the place where the accident has happened should not be in danger of another accident. So if the accident is in the middle of the road, the first thing they need to do is move to the corner of the road. After that, they should be able to log roll. They should know what log rolling is, they should know that they're not supposed to remove the helmet. And the next important thing is that in case there is a hemorrhagic bleed, then they should be able to control they should know how to tie a tourniquet and control the bleeding.
Excellent, Dr. Jitendra. Dr. Balvinder, you will agree that Dr. Jitendra has put it all together very well. So she has said in any of the patients that we need to suspect cervical spine injury and ensure that you do the sterilization and the log roll of these patients onto a spine board. And then she has said that you have to get the bleeding under control and try to shift the patient at the earliest to the hospital. Is there anything else you want to add, Dr. Balvinder? You have to unmute your...
Yes, ma'am. Dr. Jitendra has very beautifully explained the role of bystander, and most of the time they are the lay persons. But as we have become very much conscious about the trauma care. So now almost everybody it has become mandatory that everybody should know the first aid. So they should have the positive attitude. They should immediately come for help. And then the next is they must shout for help. Then the scene safety. And afterwards, the assessment of the patient immediately, their immobilization and the bleeding control. Of course, these are the factors that are expected from the bystanders, and it has become mandatory in some countries.
That's right. Very nice. Dr. Josna, do you think all the bystanders will be trained in the components that Dr. Balvinder has put forward?
Ma'am, I feel that in our country, maybe we require to incorporate this training as a public health measure to improve the management of trauma care patients, especially the pre-hospital area. So if as a policy, we start training the general public to provide this pre-hospital care, bystander care, that will be very helpful. Because in developing countries, not many bystanders would be trained for it. In fact, sometimes ignorance can do more harm.
True. So you feel that the public should be trained, and in this aspect, the government will need to take measures to ensure they support all the centers to go ahead and do the training program for the public?
Yes. And as a medical fraternity, we can join hands and make programs for public health training.
That's nice. Yeah. So I think as you put it, Dr. Josna, I think we have to come together and contribute to the training, probably hold at least one in a week.
Yes, ma'am.
And then probably that will be the first step that we can take to improve the trauma care in our country.
Yes, ma'am.
And I think, ma'am, the most important place where this can be done is in our trauma centers, because the attendants of the patients, they are more sensitive because they've recently seen a trauma. So they can be the first people whom we can target.
Very nice. So Isacon has really chosen this subject, and we have to thank Isacon for inviting us here today for this session. And pre-hospital care is going to be so important. Dr. Kaushik, what do you feel are the gaps or restrictions that come in where the bystander doesn't pitch in to help the victim?
So actually, there sometimes we can see there is some diffusion of responsibility among people who are the first witness of all this trauma. Sometimes some people will think that somebody else will help. Some will think that they have to catch a subway or a metro, and some might think that they are late. And some may actually not know what has to be done and who has to be contacted. So these are some of the impediments. So this diffusion of responsibility is actually is a basic problem, which actually does not have much solutions. Other thing impediments are like sometimes they will feel there are some hazards for the bystanders that they may be afraid of contacting some diseases because of non-availability of personal protection equipment, like because of contact with blood. They may be afraid of contracting all these viral diseases which are transmitted like HIV and hepatitis. So these may not be available immediately in the scene. So these are some of the impediments which will prevent the bystander from acting. Just they may call for help, but active in participation in cannot be happening. And other thing is legal consequences which they have to face if they help, and questioning by the police, and lot of time is spent in the hospital until the patient is getting treated. So all these things comes on the bystanders. So these are some of the impediments which
So Dr. Jitender, thank you. Dr. Kaushik has put it very well, the constraints that a bystander might come across. So considering, can this strong legal framework that we have already, and with the laws that are already available, why do you think the bystanders should be scared to help?
Well, ma'am, like as Kaushik rightly said, that the couple of factors are that they might get infection, they are busy, they want to go to their workplace, and this would take time. Other thing which might happen is that they need to go take the patient to the hospital. Many hospitals will not take the patient in before they are paid fee. So they are also apprehensive that they might have to shell out money out of their pocket to get the patient admitted into the hospital.
Yeah.
Another thing is that they are afraid of legal consequences, that police people might hold them back, and this is another reason they might not be ready to. And then the thing is, they might be framed into the scene of accident is another thing which comes into the minds of many bystanders. So all these things needs to be these concerns needs to be diffused so that bystanders are ready to help the victim.
But the law, where the Good Samaritan law that has been brought in now, Dr. Jyotsna, you agree that the bystander really need not be worried, especially when they're going to be helping a victim and trying to save the life of the victim.
Yes,
Your
ma'am,
thoughts, Dr. Jyotsna?
Yes, ma'am. With this Good Samaritan law, it has become slightly smooth for the bystander because there are no legal hassles which will be implicable on the bystander. But still, there is some resistance, probably because of other causes which are discussed. But yes, legal issues have become easy. This law.
Very nice. So now we have said the bystander can safely help the victim. Of course, taking the necessary precaution, especially with the COVID situation, keeping in mind the COVID situation and the other protective measures they need to take. And then they can actually help the victim. And the first thing probably they should be doing is call the emergency number. So now if you think of the emergency number, Dr. Balwinder, I think each state has a different number, and the government is now coming across that everybody should be calling 112, I think, across the country. So they're trying to bring in a number which will be common across the country, isn't it? So what number do they call, Dr. Kaushik, in your state?
Yeah, I'm from Kerala, and we have this KANIV, that is Kerala Ambulance Network for Injured Persons. So this is by that GKV EMRI
GVK
EMRI Institute. So it again uses this 108 number only for the ambulance. Apart from that, this is for the road ambulance. In Kerala, there is one more thing. We have got marine ambulance that uses a different number. So
what about okay.
So this is commonly used. 108 is commonly used, and this is integrated with the government. And there are some NGOs like trauma care NGO, which is called as trauma care NGO, and that has main headquarters in Calicut, and they also use a number of 112.
Okay, that's nice. But again, you see, there are a lot of numbers that they're given, public is given to call, isn't it? Other than 108, there might be other numbers also available. Dr. Josna, in Delhi, what do you think is the situation?
In Delhi, we are basically following three numbers, 102 and 108 and 112. So these are the three numbers.
Sorry. Yeah, that's right. Three numbers. Dr. Jitendra?
We have 108 in Chandigarh. And then, yeah, and then we have a separate set of police people, like police control room, which PCR vans, which are stationed at, at a distance of every 1 kilometer. And they are the people who reach the area of accident to help the accident victims.
Excellent. Yeah. Dr. Balwinder, what about your state?
In my Punjab state, just, I have updated myself. So in 2021, the government of Punjab launched 108 ambulances, 325 in 3 phases. And these ambulances, they are available in the 3 shifts, 8 hours per driver. And in the rural area, these ambulances on call reach within 20 minutes and in an urban within 15 minutes. And they are well laced with the equipments. That is, I got to know that they are having this all GPRS system, and along with that all electrocution kits, and they are well laced with the all equipments. So the latest status is very much satisfactory.
Good to hear that, madam.
So from Punjab, Chennai, Kerala, Bangalore, and Delhi. So we have 5 states over here, which has got different numbers to call, isn't it? So now I think the government, once they bring in one single number, then it might become much easier. But you all agree, like Dr. Balwinder said, it'll take about 15 minutes to 20 minutes for the ambulance to reach.
Yeah.
Do you think the public have the patience to wait for the ambulance? Dr. Kaushik.
Yeah, as I told that most of the people, when it happens, when there are a lot of people, again, there is diffusion of response. People may not wait. The other person they may try to shift the responsibility to someone and they may go. But when it happens, when you are the only bystander, then there is a responsibility of the person to wait till they call. There may be continuous
sorry to stop you, but due to constraint of time, so let me rephrase. Do all the victims wait for the ambulance to arrive, or the public take an initiative and shift the victim in whatever available vehicle to the hospital?
Yeah, a lot of times we can see that if they are 4-wheelers, a lot of bystanders who are taking the patient in their 4-wheeler car or whatever they have, and sometimes if they think that there is a lot of bleeding, and if they are advised by the ambulance, they also do shift the patient in these vehicles, but they may not be knowing the hazards of shifting such.
That's great. Yes, Dr. Kaushik. So, Dr. Josna, in your hospital, do you receive patients coming into your casualty or emergency department other than the ambulance?
Yes, ma'am. That's very frequent.
Are the victims shifted in public vehicles?
They are shifted in private vehicles, public vehicles, autos, rickshaws, and all kinds of situations. Sometimes they are carried on by their relatives and they somehow manage to reach the hospital. It's a mixed situation.
So, Dr. Jitendra, you will agree that they're going to be folded and placed into the any vehicle that is going to be available.
Agreed, ma'am. Agreed, ma'am. Yeah.
And is it a concern for us? These patients being shifted, folded into a vehicle and coming in, is it a concern for us?
Definitely, ma'am. It is a very big concern because we need to be very careful about cervical spine injuries. And the most important thing that would get exacerbated would be the cervical spine injury. So this would be the biggest hazard that these patients will have. So I don't think so they should be transferred this way.
Excellent.
And proper
Excellent. Yes.
transferring in ambulances should be done.
So, Dr. Josna, how do you think they can decide which patients they'll be able to send in an ambulance and which, that means they should wait for the ambulance, or for which patient they should actually, they can take in their private vehicles? Dr. Josna?
And if the bystander who is planning to take the patient to the hospital, it depends on the awareness of the bystander. In cases of minor injuries, yes, where they are not where there's not a lot of bleeding, there's no instability, are not suspecting any major head or spine injury, yes, they can be shifted in a private vehicle to save time. But if there is a major injury or bleeding and spine injury suspected, or it is an unwitnessed trauma, unwitnessed, people don't know how it happened, it is better to wait for expert help to arrive, call the help, and try to stabilize the patient as much as possible.
True, isn't it? And Dr. Josna, even the mechanism of injury,
yes,
does it play a role?
Yes, ma'am. Mechanism of injury is very important. It depends, like if it's a whiplash injury, if it's a road traffic accident, or if it's a assault. So mechanism of injury determines, we can predict what area would be injured more, whether there will be head injury more, whether it is cervical spine injury. We can anticipate whether there will be internal bleeding if we know the mechanism of injury. And it is also very important that we tell this to the hospital. If we are able to, if we have decided where to take the patient, if we inform the hospital that how many patients are coming, what is the mechanism
So we
of
are
injury.
upcoming with that
Yes.
situation of how we are going to be informing the hospital. I think en route care, is it going to be important too, Dr. Balvin?
Ma'am, during transportation of the victim, it depends on the provider. So if the provider is having a basic pre-trauma knowledge, or he is having an advanced, on as a whole, so he is responsible for continuous communication with the hospital to which that victim is being transported, and he is continuously monitoring patients this airway, breathing, circulation, bleeding. And if he, of course, he is ready all the time with a resuscitative measure also. At any time, if the cardiac arrest happens, he should be ready for that BLS. He should be able to manage the airway as well. So if he is having an advanced knowledge with the pre-hospital trauma, then he is capable of doing intravenous, IV line. He can manage the IV line, and he can do the endotracheal intubation as well if it is required. And it is, they are also taught about doing this needle, for thoracocentesis for tension pneumothorax. So they can do all these things if they are taught, if they are in the advanced state. That is tier 3. So, and they are responsible.
Sorry to stop you here, but do you think all this will be possible on the Indian roads with our condition, the way the roads are set? Do you think we'll be able to do all of these procedures en route? They'll be able to diagnose and do en route?
Ma'am, they are taught. Of course, the studies have shown that results are not good. So the main is, it is a quickest transport which is possible. So as primum non essere, the doing less is doing more. So,
Dr. Balwinder, I completely agree with you. And I think all the panelists also will agree that the most important thing will be to continue to monitor the patient's en route, ensure the bleeding is controlled, and we have to reach the hospital at the earliest. Dr. Jyotsna, you were just telling us that about the information that we need to give to the hospital. So do you want to elaborate a little on that?
Yes, I think the information which should be given to hospital must include the number of victims which are coming, the mechanism of injury which would have happened, the type of arrangements which would be required in the hospital, like if blood is required, the hospital will prepare itself, the estimated time of arrival to the hospital. This should be informed to the hospital, and there are various protocols which have been developed, such as MIST. One is known as MIST, which tells M is for mechanism of injury, then injuries which are there, then signs, symptoms, and the treatment which has been given en route. So if proper communication is there, the hospital can have a good pre-arrival preparedness.
So what, Jyotsna, you're trying to tell is that all of us should be speaking in the same language, isn't it? So yes, this will give a communication and at the same time the information to the receiving hospital. Yeah. So as Dr. Jyotsna has rightly put, Dr. Kaushik, once you receive this kind of an information that a patient is being brought to your
So I work in a tertiary care center, once we get such an information before the patient even arrives to the hospital, we are ready with a code, which is the code for trauma. We are in our hospital. It is designated the color of violet. So code violet will be called in our hospital.
Just to stop you there. So code violet also means there is violence occurring, isn't it? So the patient is getting either agitated or getting violent, and code violet will be called. So let us just keep it as a trauma code.
Yeah, trauma will be called. So once the trauma code is called, at least 4 super specialties will be arriving immediately to attend the patient within a span of 30 minutes. The CTVS, plastic, the vascular, and the general surgeon, and the critical care. All these people will be immediately available at the scene. And
now, if you get an information that the patient is actually arriving and probably has a major traumatic brain injury and probably some chest injury, and your hospital is a level 3 or a PHC, what do you think should be your preparation?
So for a patient with head injury and along with multiple other injuries, first we have to assess for if the patient is having any additional cervical injury and the conscious level with that alertness, verbal response, pain, and unresponsive APBU scale immediately, and we should find out whether the patient requires immediate placement of advanced airway. While
that is excellent. So that's what you're trying to put in, isn't it? Whether this patient's airway has to be secure, whether this patient's airway have to has to be so secure, whether this patient's airway has to be trauma, so whether this patient's airway has to be trauma, so whether this you have brought out the from the pre-hospital, you brought out the the patient features from the pre-hospital, you brought the airway has to be ensured, and the has to be ensured, and now the capacity is minor. Because the PHC center might not be able to manage the PHC center might not be able we should directly transfer this patient to the center. We should directly manage this patient to the center. We should directly manage this patient to the center.
Level 3 level 1 and the China level 1 that is the phase matching now level 1 that how phase matching now level 10 that how phase matching now level
'Excellent. So, Dr. Josna, you will agree with Dr. Kaushik that excellent. Again, here, Josna, you will agree with intimation and information that Josna, you will agree with giving to the center that information receiving is important, giving and also that receiving is they have to giving the time also patient that is sending and whether they will give the time also patient that. So that is another issue that we see that patient goes short. See another patient is not received at one center, and maybe it is not the fault is not received at one center, and maybe it is not the fault that pre-intimation is not given, and maybe it is not the fault to find out pre-intimation is not given, and maybe it is not the fault to find out pre-intimation is not given, and maybe it is not the fault to find out pre-intimation.
So rather than shooting the patient, the hospital should agree that okay, we will accept such and such patient. Only once they should agree that we will accept such and such patient. Only once they should agree that we will accept.
So I think we have actually done. So I think a lot of has actually done. So I think a lot of has actually gets injured. So I think a lot of has how the bystander gets injured. Then how we should have a number the bystanders how call and we can have trained bystanders how right and we have to ensure trained patients how right we follow the scoop and right. So here we follow the scoop and we have to ensure that so here we follow the scoop and we have to ensure that then ensure that and as then ensure that and a lot of trained emergency medical personnel are trained start before we start off because en route we might not be able to get IV access and we might not be able at the same time you all put it we need to all actually this actually hospitals such a patient actually whether they're in hospitals this is the patient I'm missing the moment that is the patient highlight I'm missing we can do the communication and once the patient arrives Kaushik has very well and once on how I'm missing bed has to do this very well and once on the patient has to be given bed has to do this very well and once on the I think the situation where we have systems approach for the
way you have spoken it, it like that, probably you would be able to. Way you have spoken it, like that, probably you would be able to.
So just as a take-home message, so just as a take-home message, just as a take-home message, on a take-home message, what you would like to give to the on a take-home message, what you would like who wants to provide trauma care, who wants to provide trauma care,
when most important thing which I think is when they starts public awareness program, which I think is when communities starts public awareness program, because they are going to communities and how are they going to the bystanders, because they are going to communities and how are they going to the bystanders, because they are call the ambulance. At least move the patient to the side. Call the
Great.
ambulance.
Dr. Balander, how do you think in your experience that how the emergency medical services gaps that we have identified, how can we improve them? Gaps that we have identified, how can we improve them?
I would say, right from the role of the bystanders, the role of the bystanders is right from the vital. They say that the role of bystander is vital. They say that the role of the bystander is vital to minimize the patient.
So let's assume lung.
Hello. Yes. So there was problem in the voice and video was not doing good. So any question from the audience?
What was the need of lung?
I am shifting to Harsha then. Harsha, any question about the trauma?
Thank you. Thank you.
Hello, good afternoon. Thank you all panelists for a nice information. In addition to that, I want to add 2 points. One, we should spread the message, do no harm to all trauma victims. And second is right person to the right hospital. So whenever any trauma victim is taken to any hospital, that facility should be available. So golden hour will not be passed. Any comments from the audience?
Can I leave the meeting now? Okay.
Nice message also given by the Harsha also. There should not be loss of the golden period also, and bystanders should also have a good transportation system. Thank you, sir. Thank you. Thank you. Thank you all panelists. Thank you, Harsha. Thank you, everyone. Thank you, organizers, for giving opportunity. Thank you very much. So we conclude the session. Thank you to all. Thank you, organizers. Thank you.
Thank you.
So we thank Isacon 2021 for giving all of us an opportunity for being on this platform today. Pre-hospital care is a need of the hour, and I thank all the panelists for participating in this session and giving their inputs on how we can improve the process of pre-hospital care.
Thank you so much, ma'am, for conducting this panel discussion in such an interactive and informative way. It was a great experience. And thank you, Isacon.
Thank you, Isacon, for giving me this opportunity. And I also thank my moderator, Dr. Aruna ma'am, and all the participants along with me in the panel. It was a nice experience.
Welcome everyone. We are starting our next session now. The topic of the session is special. Welcome everyone. We are starting our next session now. The topic of the session is special considerations of ear in anesthesia. We have four chairperson for this session: Dr. Amita Patel, Dr. Mrunalini Patel, Dr. VM Divekar. Now the session is continued.
Challenges in onco-anesthesia. Good afternoon, everybody. I thank Isacon for giving me this opportunity to be part of this national conference. I'm Dr. Namrata Rangnath, professor in Department of Anesthesiology and Pain Relief, Kidwai Memorial Institute of Oncology, and I've been practicing onco-anesthesia from last 25 years. If you see the statistics, the National Cancer Institute projects the worldwide number of patients with cancer to increase by 50% from 14 million in 2012 to 21 million by 2030. And the number of cancer-related deaths is projected to jump 60% from 8 million in 2012 to 13 million in 2030. So if you see that though patients with cancer are similar in many ways to those without cancer, the unprecedented growth in cancer patients necessitates that onco-anesthesiologists be acquainted with the impact of cancer, its therapies on the patient, and associated challenges with it. So if you see, majority of challenges anticipated by an anesthesiologist are encountered in onco-anesthesia, be it starting from an IV line to a difficult airway, massive fluid transfusion, massive blood transfusions, prolonged surgeries, you name it, and it is there in oncoanesthesia. But there are certain specific and unique challenges to oncoanesthesia, being malnourishment and cancer cachexia, systemic effect of the disease, effect of anti-cancer treatment, local effect of the disease, cancer-related pain and their associated medications, and psychosomatic factors. These patients, along with these specific challenges, come with the comorbid conditions like elderly, long-term smokers, alcohol abusers, COPD and emphysema, associated IHD, cardiac failure, and myocardial dysfunction. But if you see the specific challenges, the first and foremost being malnourishment. So when we come across cancers of GI, colon, ovary, and all these patients are really malnourished, and they lose their fat and muscle mass and causing a lot of disturbances in their homeostasis and metabolic alteration. So if you see that weight loss per se doesn't tell us anything more about the nourishment, but at least it can guide us whether patient needs to be, replenished or is undernourished, because these patients can have, if you see the weight can be because of the tumor mass or ascites or edema though too. So the prevalence of malnutrition is high in patients who are submitted for surgery, ranges from about 35% to almost 60%. So this nutritional deficiency can be because of the cancer itself, which can be either in the head and neck or, in the GI, where, either he is not able to eat or he is not able to sustain the food, or the metabolic alteration due to the disease, post-chemotherapy issues like he can have an intractable vomiting, or he has lost the sense of smell and taste, or, because of that, he's not able to eat, or a cancer cachexia where weight loss, anorexia, weakness, poor performance, and impaired immune function is there. So what happens is when they lose their fat and body mass, you all of us know that the IV anesthetication, they'll be much more in the free form. And this malnourishment can, the patient can be more prone to hypothermia, hypoglycemia, pressure sores, and refeeding syndromes. A major factor being hypoalbuminemia, and more so in patients with CA stomach and CA ovary, where hypoalbuminemia can lead to delayed wound healing, surgical site infection, poor functional status, delayed recovery, impaired muscular and respiratory functions, increased perioperative mortality and morbidity, and poor clinical outcomes. So for an anesthesiologist, albumin is very important because it is what is maintaining our oncotic pressure, and we are not able to, if it's low, we are not able to maintain the blood pressure. We need to really be very precise in our food management, because little more can cause pulmonary edema, and definitely we need to take care of the use of the drug doses too. Coming to the systemic effects of cancer, what cancer per se can do is it can have its hematological effects, where it can be either because of the primary malignancy of bone marrow, metastasis, or myelosuppression chemotherapeutic agents. So patient can develop anemia, leukopenia, thrombocytopenia, and always remember that cancer produces a hypercoagulable state. So thromboprophylaxis should be used and is a must. Coming to a paraneoplastic syndrome, another systemic effect, that is, these are the substances which are secreted by the tumors. And what are more important for anesthesiologists are named, some of them are named here, like some of the tumors can, secrete ACTH, ADH, or parathyroid related hormones, insulin-like growth factors, erythropoietin. So depending upon what is secreted, we need to take care of. And it can have its own anesthetic implications. These paraneoplastic syndromes can, express as neurological syndromes when if a thymoma is associated with myasthenia gravis or Lambert-Eaton syndrome, where you need to take care of the anesthetic implications of prolonged respiratory depression, hypersensitivity to non-depolarizers, risk of cholinergic crisis, and in Lambert-Eaton to see that hypersensitivity is there for all muscle relaxant and there's no response to neostigmine. These patients can also have, they can be on steroids, and they can have, tumor lysis syndrome. So there may be other things associated also in these patients. Effect of anti-cancer treatment, chemotherapy and radiotherapy. Now, with so much of, upcoming chemotherapeutic drugs, patients are being, taking a lot of chemotherapeutic drugs before they come to surgery as a neoadjuvant therapy or a chemotherapy. So it is necessary for an oncoanesthesiologist to be aware of what the patient is on before he comes for the surgery and what implications it can have on the patient and the anesthesia. So as you see, the chemotherapy drug, apart from the cytotoxic effects on malignant cells, they also have a toxic effect on normal body cells, which are responsible for their side effects. So if you see here, a cardiovascular complications can occur with anthracyclines, that is our doxorubicin, adriamycin, where you can develop a dose-related cardiomyopathy. They have a cardiotoxic effects, and these drugs are very important for an anesthesiologist. So that, remember, if a breast case is coming who's received these drugs, we have an echo before the chemotherapy, but we have to make sure that we have a one after the chemotherapy too, so that we can know the cardiotoxic effect. Coming to the respiratory, yes, the most important being for us is the bleomycin, which can cause oxygen toxicity and later fibrosis of the lung. We have many drugs which can cause gastrointestinal complications or renal complications. Very important is cisplatin, which is commonly used. And then the electrolyte abnormalities and bone marrow suppression, which many drugs do. So need to know, and one more important being the neurological effect, like when Kristen and all, if you have a neurological defect, we need to be sure that we document it before we give our regional anesthesia for medical legal issues too. If you see this girl, she underwent chemotherapy and came for surgery. When the echo was done, in that echo it was found that it was left ventricular global hypokinesia was there and reduced LV global function. So this is where the investigation to the echo is very important for us if the patient has taken a cardiotoxic chemotherapeutic drug. Coming to radiotherapy, as we said, how much radiotherapy is advanced now, like previously, used to get side effects from all over the area. Now they can calculate, give to the particular area. And, the amount of side effects have definitely decreased now as before. And it is used now, not only for treatment, but a lot of palliation too. So radiotherapy, if you see, it can have its own complication. It can give a generalized reaction. It can, give a head and neck. It can change the airway. In CNS, it can give a peripheral neuropathy. You have a pulmonary, you can have a, pneumonitis. Cardiovascular, when it is given in the mediastinum, it can cause, it can affect the SN node, and you can have cardiac conduction defects. You can have conduction arrhythmias. Can have myocardial ischemia by coronary fibrosis. There can be radiation nephropathy given in renal, or a hepatopathy can also occur after radiation. And very important is that whenever radiation is given in the vicinity of any gland, it starts hypofunctioning, whether it's a thyroid or adrenal or a pituitary. And very important to us, the anesthesiologist, is when the radiation is given in the head and neck area. So what it does is that when the radiation is given, it can lead to trismus, limited mouth opening, limited neck extension, limited mobility of pharyngeal structure. All these can complicate airway access. And sometimes it happens is that you may have a good mouth opening, but when you put your scope inside, your epiglottis is totally fibrosed and you're not able to lift the epiglottis, because as radiation was given, the first edema developed and later it turned into fibrosis. So any patient like this, you can have an intubation difficulty or impossible with conventional laryngoscopy. So we need to be very much aware when you are taking a case of post-RT in head and neck for anesthesia. Always elicit the history. Is the patient post-CT or RT? And depending on that, plan your airway management. You can see this 2 patients with restricted mouth opening. Coming to the localized effects of tumor. A tumor itself can, have its compressive symptoms, or it can, give a mechanically or a tissue destruction, can cause ulceration or a hemorrhage. So if the tumor is in head and neck area, it can cause a supraglottic or an infraglottic obstruction. It can do a recurrent laryngeal nerve damage, and the worst being a superior vena cava obstruction. So accordingly, we need to take care of the patient. If you see this patient, he has a right neck mass, and you see the compression which has caused and shifted the trachea totally towards the left side. If you see the CT scan and X-ray, you see the narrowing, or the diameter is so less of the trachea in this case. One of the most challenging tumor being the mediastinal tumors, which can cause tracheobronchial, cardiac, and great vessel compression to a great extent. So an induction of anesthesia may result in an unventilable patient or a catastrophic reduction in cardiac output and subsequent death. If you have huge masses, which can be any, and especially the ovarian masses, if you see, the masses themselves can cause localized effects by decreasing the venous return, diaphragmatic splinting, reducing the gastric emptying, making the patient like a full stomach, and proximity to major vessels, which may cause much more bleeding. And the location of the tumor and the extent of metastatic spread, extravascular fluid accumulation can be significant, and all this can lead to ascites, pleural, and pericardial infusion, and accordingly, they can have their pressure symptoms too on the patient. Coming to the pain in cancer patient, another challenge, because most of these patients who come to us for surgery may have received multiple analgesics, and they may have some degree of tolerance and require dose escalation in the post-operative period. So a thorough drug history with detail of analgesic use should be elicited. Coming to investigations, yes, very, very important. Besides routine pre-operative investigation, you may require echocardiography, cardiopulmonary exercise testing, lung function test, imaging, very important in head and neck cases where you need to plan your airway and you need to see whether you need to do only X-ray or a CT scan or a virtual endoscopy or a 3D picture, or you want to do a bronchoscopy. You need to, and remember, a team coordination is very, very important in this. Reading the imaging with the surgeon, planning your airway management is very, very important in anesthesia. And imaging of chest when you have a mediastinal tumor or a lung tumor or abdominal masses is equally important. So once we have diagnosed them and they're supposed to come for surgery, and when you have done their investigations and history is very, very important in all these, in patients where, the tumor is obstructing the airway, where we can take history of whether in supine or patient becomes, breathless, or all these histories can give you a clue. So once you have taken the history and you have done the investigation, you need to rehabilitate them. Basically, what you want to do is enhance the functional capacity so that the patient can withstand the stress of surgery and improve treatment compliance in the post-operative period. So optimize the medical illness, physical activity program, nutritional measures, and especially strategies to allay anxiety. Intraoperative, very important because they are more prone to complications because of disturbed homeostasis. Intraoperative monitoring, your standard monitoring, and invasive monitoring wherever clinical condition of patient mandates. Coming to some, challenges in specific surgeries which are very, very challenging. The head and neck surgeries being very, very common, where if you have a laryngectomy, not only your airway, your management of the stoma with apneic technique and post-op, just leaving the patient, taking care of the post-op care of stoma are equally challenging and important for an anesthesiologist. If it's a laser surgery, yes, communication is the key. You're sharing the airway with the surgeon. You are sharing the area where it's being operated. You are using a smaller size tube. You are using a laser tube. Are you able to ventilate the patient well? Then are you prepared? Your OT is prepared for a laser surgery, and at the same time, are you prepared if by chance a fire occurs? Coming to these complicated thyroid surgeries, yes, all of us do a lot of normal thyroids where there are small thyroids where, you do, besides the routine, we do the thyroid function tests, their x-rays, their CT scans. And then here again, you need to be very, very concerned about how to manage the airway, because here that chances of upfront tracheostomy is also not there. So this is another very challenging case for the anesthesiologist. Along with, if the trachea is infiltrating the trachea, you can have a case for tracheal resection too. If you see all these oral surgeries, what a challenge it will be to manage these difficult airways. So yes, your clinical history, your imaging, and your discussion with surgeon, and your gadgets, and your clinical acumen, all are equally important in managing these airways. Coming to some of the few common and important surgeries which are challenging is the esophageal surgery, where you can have a transhiatal esophagectomy, you can have a thoracic, laparoscopic, or robotic, where we need to take care of the cardiorespiratory fitness, the nutrition of the patient, airway consideration, whether we want to give one lung or a fluid management, surgical manipulation of hiatus and mediastinum, sudden cardiovascular instability, delivering the mobilized stomach, inadequate compression of IVC, sudden decrease in cardiac output, and you having sudden arrhythmias and a balanced analgesia is very, very important in thoracic or esophageal surgeries. Coming to liver resections, yes, a lot of liver resections. You have patients which may be malnourished, reduced physiological reserve, increased chances for infection, renal compromise, impaired cardiac function, extra risk of bleeding. At the same time, if liver functions are impaired, it will change our way of giving anesthesia, whether the drugs which we use, which are metabolized by the liver, whether we will give regional or not. We need to have decide whether it's important to have epidural or not, and whether we'll be able to remove the epidural if after the surgery the liver functions are deranged. Coming to another important surgery, the Whipple's procedure. Yes, in obstructive jaundice, a major surgery, Whipple surgery, where you can have bilirubin ranging from 8 to 10 to 16 to 20 or 22 or more, which can affect our cardiac and renal system, causing severe bradycardia, decrease in cardiac contractility, and getting deposited in the renal glomeruli. So what we need to do, whether we need to do a pre-op stenting, whether it is more helpful to the patient or directly going for the surgery, patient's nutrition, patient's glucose control, thromboembolism, coagulopathy, all need to be taken care in with this procedure. Coming to gynec oncological surgery, I would say that there is no surgery like gynec oncosurgery which teaches an anesthesiologist. So it can be an ovarian cancer, radical hysterectomy, pelvic excenteration, radical vulvectomy, brachytherapy, laparoscopic, or a robotic surgery. You need to take care of cardiorespiratory, supine hypertension syndrome, neurological symptoms, venous thromboembolism, ascites, malnourishment, paraneoplastic syndromes. So gynec surgeries are real challenge for the anesthesiologist. Coming to hypothermic intraperitoneal chemotherapy. Now, Society of Oncoanesthesia have come up with guidelines how to manage the cases of hypac. Remember, extensive surgery followed by chemotherapy at high temperatures. So normovolemia, correcting metabolic derangements, perioperative management, prevent development of coagulopathy, thorough knowledge about the adverse effects of chemotherapy used during the hypac. Coming to pneumonectomies, yes, pre-op assessment, pre-op rehabilitation, one lung ventilation with prevention of hypoxemia, physiological changes with lateral decubitus positioning, fluid and post-operative management, and post-operative complications are very important pneumonectomies. Coming to urological cancer surgeries, yes, you have nephrectomy, cystectomy, orchidectomy, RPLNDs, you have radical prostatectomies, you have robotic now. So often they are lengthy and typically involve the abdominal or pelvic body cavities with uncompromising patient positioning, major hemorrhage, and fluid balance. So these patients with urinary diversion can experience some specific metabolic problems where the colon or ileum has been used as a conduit. So absorption of chloride with concomitant secretion of bicarbonate can cause a normal anion gap hypochloremic acidosis in this patient. It needs to be taken care of. Thromboembolic disease remains a significant cause of perioperative morbidity and mortality in such cases. Plastic and reconstructive surgeries, yes. Here, anesthetists need to take care of the airway first, then the prolonged procedure, ensure optimal perfusion of transplanted tissue while minimizing morbidity associated with prolonged surgical time. You want tissue flaps which should function. They're particularly vulnerable to edema. Large volumes of crystalloids are avoided. You need to take care of your vasoconstriction. It has its own clinical implications, plastic and reconstructive surgeries. And the last and not the least is the robotic assisted surgeries, which can be anything from oral, head and neck, to the thoracic robotic surgery, to abdominal, pelvic, you name it, and a thyroid robotic, everything is there in robotic surgery now. So it leaves the anesthesiologist with some central issues like lines, monitors, and patient protective devices, restricted patient access. Once robot is engaged, visitation and access to airway is difficult, patient positioning, consequence of pneumoperitoneum, hypothermia, venous gas embolism, subcutaneous emphysema, occurred blood loss, and even extubation too. So there was a time when it used to take 7 to 8 minutes for us to undock if an emergency occur. But now with the new machines, it's very easy to dock. I should not say easy, but can be docked. The robot can be undocked in less than a minute. So on organization level, teamwork and communication between anesthetic staff, surgical staff, and nursing team is imperative in terms of robotic setup and docking and undocking, particularly in the event of an emergency such as cardiac arrest. Simulation has been recommended to improve efficiency in these circumstances. So if I summarize, anesthesia for patients with cancer pose significant challenges due to physiological derangements because of multifactorial causes. A thorough preoperative assessment with correction of nutritional status and electrolyte abnormalities, careful intraoperative planning and monitoring, and intensive post-operative monitoring is essential for positive outcome of the patient. Thank you.
Good afternoon, everybody. It is with great pleasure that I am here today at the Isacon 2021 Ahmedabad, and I sincerely thank all the organizers for having me here. My topic today is non-operating room anesthesia, tips and tricks. Now, what is non-operating room anesthesia? It denotes anesthesia which is administered for all procedures which are performed in locations other than the operating room. And it caters to varied specialized procedures carried out in diverse environments in remote locations of the hospital. For example, endoscopy suites, cardiac cath labs, interventional radiology suites, and interventional pulmonary suites, amongst others. These procedures range from simple daycare procedures to complex cardiac procedures, which may require care in the intensive care unit. They present different challenges from those confronted for procedures performed in the OR for various reasons, which we will see during the course of this talk. So these are the various operating room sites like radiology, gastro, cardiac interventions, intensive care units, etc. Earlier, the cases managed outside the OR were minor, they were infrequent, and they involved relatively stable patients with limited comorbidities. These days, the scenario has changed, and we have very complex cases coming in who are very high risk, and the presence of anesthesiologists is required for all these cases. So, as I mentioned earlier, the anesthesiologists now have an increasing presence in the non-OR procedural rooms. And over the last few years, because of rapid technological developments and innovations, NORA cases have expanded and they involve almost every medical specialty. Now, why is NORA risky? Whoever has gone for these cases definitely will agree with me that there is always a small, a small amount of tension and the feeling of being a risky procedure when we go for these NORA cases. This is basically due to various reasons. NORA is performed in a high volume and it is a fast-paced environment in a workspace which is not actually optimized for anesthesia care. Some of these procedures may be minimally invasive, but anesthetic issues may be very complex. An analysis of ASA closed claims revealed that patient mortality was almost double that seen in the OR, 54% in NORA, whereas 29% for OR claims. They involved elderly and medically complex patients. 38% were older than 70 years and 61% were classified as ASA 3 to 5. The most common NORA claims were related to severe respiratory events, and it was found that the care was actually substandard and the complications could be prevented if they had adhered to basic ASA monitoring standards. Now, various factors contribute to the risks we face in NORA: patient factors, location factors, environmental, operation, and communication factors. Taking them one by one, the patient factors, most of the patients, like I mentioned earlier, are elderly patients. There are increasing number of patients which might be of higher ASA class, maybe class 3 to 5 compared to the OR. And because technology has advanced and the operators have become more and more expert at performing these procedures, they perform them on patients with complex comorbidities. Regarding the location, most of the times these locations are remote to the main OR section. Nearby supplies are lacking. There is a delay between the request for assistance and the arrival of help, and there is questionable safety of anesthesia in these remote locations. Coming to the environmental factors, the anesthesia professionals are specifically trained to operate within the OR, which is very organized. It has clearly delineated roles and practices. But these venues where you perform NORA procedures, they're smaller, they're less flexible than the OR. And non-OR procedure suites are organized from the perspective of the proceduralist, and the needs of the anesthesiologist are often overlooked. There is lack of storage space. So when you want something, there is a longer turnover time because you need additional anesthesia technical services to go and bring those things. Electrical outlets may not be adequate. Gas scavenging definitely may not be available. And oxygen and suction outlets may be suboptimally placed. Workspaces may be cramped and provide restricted access. This does not support our anesthesia needs. For example, the area around the head of the patient is crowded due to constraints of the room and equipment, and the restricted patient access may interfere with anesthesia administration. There will be difficult access to anesthesia equipment, pumps, intravenous lines, monitors, medical gases, medications, supply, and other rescue equipment. Visibility is a big issue. There's lack of visibility of procedural screens, of our monitors, and even the patient due to obstruction by equipment used for the procedures. The areas are also dimly lit, which contribute to the lack of visibility. There may be loud noise level, and of course, most of these procedures now use imaging, and the risk of exposure to ionizing radiation is high. The anesthesia team is therefore burdened with providing care in these non-ideal settings, and they may hinder the provision of quality care, because in this very limited space, we try to minimize the equipment use, and when our focus is distracted from the patient care due to an unfamiliar environment, it can be potentially disastrous, especially in case of a new procedure or a complex procedure in a high-risk patient. Coming to the operational factors, now NORA is equally demanding as compared to surgical OR procedures and requires the same meticulous planning and attention to operational efficiency. There may be lack of anesthesia or pharmacy support staff, and equipment and supplies may be unfamiliar to the people working there. There's lack of rigorous preoperative check. Pre-procedure evaluation may not be optimal because you may not have enough time, and the anesthesiologist may have very little time just before the procedure to perform a preoperative evaluation and may be forced to cancel or delay cases at the last minute. Many of these cases are deemed to be urgent or emergent, and again, there is lack of time for a proper evaluation. With new technology and non-invasive methods, the proceduralist may change his procedure or extend his procedure after it starts. So we do not know how long it will last and what the sequence of events may be. That again is an additional risk for our proper working. Other operational procedures, they are likely to start after normal working hours. And again, this will hinder the availability of critical resources. There may be personnel who are not actually trained with these procedures. The post-operative period may have limited monitoring facilities, and post-operative teams may also be inexperienced. So because of all these constraints, there will be difficult scheduling of cases, and there will be a lot of time lag and waste of time. Coming to communication factors, now normally we are used to working with a surgeon, but this time we are working with a medical interventionalist. So there is definitely a culture gap. We do not understand each other and each other's needs. So this can affect the interactions between proceduralists and anesthesiologists and undermine the communication. And therefore, there is lack of team familiarity and support in these cases. Monitoring factors. Now, monitoring is the most important thing in these cases. And in spite of monitoring guidelines, we may not be able to implement uniform monitoring in NORA settings. The equipment may be outdated or malfunctioning because nobody has given much importance to the setting up of these areas. And they may not function properly also because of interference with mapping systems or other electronic interfaces. Now, how do we improve the patient safety? As we all know, the quality of anesthesia and patient safety is of utmost importance, and there are specific guidelines by APSF and ASA to overcome these problems. What they recommend is that we should adhere to the same standards of anesthetic care as in the OR, whether it is space, availability of equipment and supplies, or perioperative management for safe management of NORA. So the anesthesiologist should ideally be participating in the planning of the NORA locations, starting from the right in the beginning during the initial meetings, whether it is for a new construction, expansion, or remodeling of already existing location, to ensure that the needs of all the people working there are met. We should familiarize ourselves with the location, equipment, and the available staff, and all the important cards like the difficult airway, hypothermia, code blue cards should always be kept in mind. And we should always determine where the backup personnel will be available and how to reach them. Every case should be adequately prepared, and you should ensure that personnel and equipment are ready, and rescue medicines are adequately in supply. And quickly, if there is a necessity for additional medication and equipment, we should have a process in place with which we can quickly retrieve them. Now, protocols and checklists are very important. So we should develop proper safety protocols and checklists, not only for regular work, but also for emergency procedures, for a response to adverse events. And every now and then we should evaluate each step of this protocol and pathway. The protocols help in us to standardize care, to provide reliable and consistent safe results. And they provide a uniform NORA environment for all those who are working there and for patients. And they're helpful because we have a protocol in managing familiar and unfamiliar cases. And even when unfamiliar staff come there, we can provide uniform care, not only in regular hours, but also during off hours or emergency cases. Now, patient issues. The most important thing is that we should evaluate the patient well before the procedure, and learn the procedure. We should be familiar with what procedure is going to be done on the patient. The comorbidity should be looked into, and we should see how many preoperative consultations we are doing each day, and compare it to the number of cases, and try to do more and more preoperative consultations. Coming to operational issue, all non-OR cases should be scheduled properly in order to save time. They should be managed, if possible, in the electronic database, and we should create a block schedule that takes into account all the factors like the provider needs, and if there are many areas of procedure, we should utilize all these areas well, and we should also take into account patient arrival times and other issues which are affecting utilization. The anesthesia provider must work with the procedural team well to assure the safety of all these patients. And there should be a real-time communication between the anesthesia team, the proceduralist, and all the other staff throughout the procedure, starting from the beginning up to the post-operative period. And the staff should get regular instructions from us, and also be evaluated at intervals to ensure that they comply with the safety protocols. And to maintain this quality, we should continue quality assessment, not only of the preoperative process, but also of the other protocols. And if there are any case delays or cancellations, we should find the reason and how many have been affected by this. If there are any barriers to sharing information, we should identify and address those barriers. If there are any complications, we should report these complications and review them by a multidisciplinary committee. Now, equipment and monitoring. Many NORA-related complications can be prevented by vigilant monitoring, and we should maintain the same standard of care as used in the OR, like I mentioned earlier. The ASA monitoring standards should be instituted in all NORA environments. All the necessary equipment should be checked regularly, and there should be routine maintenance. and improperly functioning equipment, suboptimal workspace, and inadequate support should not be overlooked. We should try to correct all these factors for safe anesthesia. Monitoring should also be visibly accessible to the anesthesia team, and this should be arranged before we start the case. Now, ASA published a statement on NORA locations, and they updated it in October 2018. These are a few points which they mention in the statements. The first one being that there should be a reliable source and backup supply of at least a full E-cylinder of oxygen, adequate for the whole length of the procedure. Reliable suction, there should be scavenging of waste anesthetic gases, which usually is not there. A self-inflating hand resuscitator bag should be there, which will administer at least 90% oxygen. There should be adequate anesthesia drugs, supplies, equipment, and the monitoring equipment should adhere to the standards for basic anesthesia monitoring. The anesthesia machine should be equivalent to those in the operating rooms and maintained at regular intervals to current operating room standards. Electrical outlets should be sufficient so that we can plug in any of our equipment without any shortage. There should be proper illumination, not only of the patient, but also of the anesthesia machine and monitoring equipment. Enough space should be there for our equipment and for our personnel, and to allow speedy access to the patient, anesthesia machine, and monitoring equipment in case of an emergency. There should be a cart, emergency cart with defibrillator, emergency drugs, and other equipment to provide cardiopulmonary resuscitation. Adequate trained staff must be available, and there should be a reliable means of two-way communication to request assistance. And of course, all applicable building and safety codes and facility standards should be observed. Appropriate post-anesthesia management should be provided for, and not only the anesthesiologist, there should be enough people of enough trained staff and appropriate equipment for safe transport of the patient to a post-anesthesia care unit, which of course should be as well equipped as these NORA locations. So these are a few monitors and equipment for non-operating room and like oxygen, wall gases, environment requirements like machine, suction catheters, intubation equipment, monitors like oximetry, capnography, BP temperature, and transport capability. Now about recovery and discharge. The anesthetics used in the NORA areas should allow rapid recovery. Physicians should be able to assess home readiness in a simple, clear, reproducible manner. There should be documented objective evidence that patients' discharge criteria were met. Regarding training, we should emphasize technical training to address the specific concerns of NORA, and teamwork training, orientation to all the staff will help develop familiarity with each other and the location and cohesion amongst the whole team. And this is especially valuable for those people who are less familiar with the NORA work environment. Now, in spite of all this, adverse events can still occur. And so we should have a reliable, proactive method to define and examine potential errors and near misses. And when these events do occur, it is important to have a system in place to evaluate them and prevent further occurrences. Debriefings, root cause analysis, and continuing education program help a lot in quality improvement. So now to conclude, NORA is an upcoming field that facilitates the availability of procedural care for a wide variety of patients. Emerging new technology to treat a wide variety of conditions will continue to present new challenges for the anesthesiologists providing NORA, and a better understanding of associated risks and intricity of safe practice will allow anesthesia professionals to be at the forefront of this rapidly evolving and expanding subspecialty. Thank you very much.
Thank you, ma'am. Thank you for your presentation. Very well covered. As an anesthesiologist, we face more challenges, but with proper planning, we can better win the battle. Well present.
Ini mama buka bagi. Ada. Mari pun
Please go ahead with the next presentation.
Good afternoon, everyone. I would request the host to start my pre-recorded presentation. RN, that is chemical, biological, radiological, and nuclear scenario. I'll request the host, please.
I'm recording this video on a morning of a working hours, and I will be talking about preparing for chemical, biological, radiological, and nuclear hazards. In other words, this is called a CBRN scenario. We all must know one thing, that we give anesthesia, we are very good in our profession, but however, we are always at the forefront whenever a problem arises. We have seen this during the COVID pandemic, that anesthetists were the foremost specialists who were caring for patients, and we will continue to do so. But for this, we all must be prepared for something which is lurking just around the corner. This is a danger, ever-present danger, and we all must know about it. So we go ahead with this important presentation in the whole gamut of things, and I must impress upon you all that this small presentation will improve your knowledge regarding this topic. So the first of all, the question was why this topic. So it's exceptionally important in today's scenario with our restless neighbors who always threaten to do something which we are not very comfortable with. Secondly, we see every now and then there is a tanker blast, chlorine leak, ammonia leak. We saw in 1984 that there was a leak of methyl isocyanate of phosgene gas in Bhopal. So we all must know how do we deal with this. There is in army there is a week-long seminar for this CBRN. What I'm going to talk in half an hour is just a very brief overview. And I would really request all of you that if you have queries, you can please direct it to my email address. I will try and resolve them. So we first come on to the chemical warfare agents. Now, chemical agents I will be dealing in very great detail because they are very common and this keeps on happening every now and then. We are ignorant about it. We just shy away from it. But then any time we can get sucked into it and we have to care for these patients. So come to chemical warfare agents, they are basically poisonous chemicals that can kill, injure or incapacitate humans. And they were initially synthesized with the aim to produce physiological immobilization in war, but then they have so many more applications which I'll be coming about. They are, in other words, a poor man atomic bomb, and they can have a massive effect on the population per se. They are basically disseminated as aerosol or gas and have a respiratory or skin contact. If we think about it, so these chemical agents, what are they? We can see this chlorine is there. Now chlorine is the least poisonous of all. In 1984 Bhopal tragedy, phosgene gas was released, which is just few times over phosgene. But then you see these gases, hydrogen cyanide, mustard, which is the most common of all, sarin and VX. Now we have to realize that they are exceptionally poisonous chemicals and we must know about them. So what are the characteristics of chemical warfare agents? They are generally liquid and they are disseminated as an aerosol of gas. They have a direct contact with your lungs and skin, and they are very much influenced by weather conditions, wind, and other cold conditions. The routes of entry, like I said, inhalation through lungs, ingestion by mouth, absorption through skin. It can be absorbed through unbroken skin, so it is not required that there should be cut on or laceration on the skin, and they are injected through punctured wounds. Why should chemical warfare agents be used? They are very cheap. They are very easy to manufacture. Almost anybody can do that. Any rogue nation, any rogue company can do that. Very small amount is needed in enclosed space. For example, you think of a mall. Mall has an air conditioning system, and through air conditioning system is some gases put. You can just imagine the amount of destruction which can cause in a mall. 3,000-4,000 persons are always there in a mall at any point of time in the evening. They are difficult to identify without proper detection systems. Nobody will come to realize what has happened. It can impact large areas. It can overwhelm existing resources. What are the forms? Very innocuous: water bottle, Coke can, pen, LPG cylinders, sprays, inhalers, oil containers. You will not come to realize that this is the inciting agent. How do we classify them? They are classified as nerve agents affecting nervous system, vesicants which cause blisters, blood agents, respiratory poisons, lung injurants like chlorine, phosgene, irritants, defoliants, and psychochemical agents. Coming first to nerve agents. Nerve agents are G agents and they are basically organophosphorus compounds. They disable enzymes for transmission of nerve impulse like tabun, serine, cycloserine, and soman. They are really poisonous chemical warfare agents. So what are the symptoms? The early symptoms of organophosphorus are the small pupils, blurred vision, increased salivation, tightness in the chest, later headache and sweating, and then dangerous symptoms are muscle paralysis, suffocation, and death. Second is blistering agents. Blistering agents are mustards. And this mustard, sulfur mustard, nitrogen mustard, they are very, very bad. They cause blisters on the skin and respiratory tract, mucous membrane, and eyes. Let me show you some grotesque photographs. Just imagine how efficiently a chemical warfare agent can act and how can they get absorbed. See this. This is a napalm bomb of Vietnam. Third is blood agents, cyanide. What we know of cyanides are they are respiratory enzyme poisons, and they can actually stop cellular respiration. Stopping cellular respiration in a cell will kill the organism very, very rapidly and efficiently. Choking agents. Now these choking agents are chlorine or phosgene, and they actually can cause cough, breathing problems, and chest congestion, and can choke a person to death. Psychological chemical agents like hallucinogens, these benzylates and LSD, they'll not let people take a corrective action, and they will be just dazed. How do we come to know that a chemical agent has been used? Unusually dead or dying insects, animals. Unexplained casualties such as multiple victims, serious illness, nausea, disorientation, difficult breathing, convulsions, and definitive casualty patterns. Unusual liquids, spray of vapor, droplets, oily film. There is one odor, which is garlic odor of only few chemical agents. Low flying clouds, fog unrelated to weather. suspicious device or package, if you suspect, it can be in a form of letter bomb also. Unusual metal debris, abandoned spray device, unexplained munitions. Actually, the truth is it is very difficult to find out whether a chemical agent has been used or not. Sometimes you may not come to realize it. Principles of treatment. Pre-treatment, will not come to know whether actually a person is being exposed. Termination of exposure, very important. Decontamination, wash liberally with water. Atropine, it is best to treat acetylcholine esterase. Oximes like pyridoxine, diazepam, lorazepam, midazolam to prevent convulsions, oxygen and assisted ventilation, and symptomatic and supportive treatment. Coming to each one, nerve agents, treat with atropine, oximes, benzodiazepines, oxygen, assisted ventilation. Blister agents, supportive and symptomatic management, levocyte we use. Blood agents, management must be rapid and very effective, assisted ventilation with oxygen, nitrites, sodium thiosulfate. See, all these are just about supportive treatments. Actually, all these chemical warfare agents, very difficult to treat them. The only thing is for primordial prevention. Choking agents, again, supportive symptomatic management. Riot control agents, they are basically used as like you must have seen this riot gas, which we tear gas. So the only idea is rapid removal from further exposure, and that is what is required in a riot. Just run away from it. Washing eyes with water and decontamination. Now coming to the next class of agents is a biological agent. This we are now very conversant with because of these COVID which has occurred in the world, which is quite unexplained. Now, what are biological agents? They are viruses, bacteria, fungi, and other derivatives like toxins. A biological weapon is a combination of these biological agents and their derivatives, and the means of keeping the agents alive and delivering it and dispersing it in the target population. That is a biological weapon. But then let us realize one thing, that these biological weapons are also quite hidden, and most of the times we may not come to know of it. CDC has classified these biological agents into category A, B, C. Category A is easily transmitted, disseminated from person to person, high mortality, affects large number of cases, causing public panic and social disruption, and requires special preparation. Now, are you having any deja vu? All of us must be having it. These are category A agents, category B agents, which cannot be transmitted very easily, but then they can disrupt social systems. Category C, they are emerging pathogens. I don't know how WHO has come to, CDC has come to this of emerging pathogens, and they have put COVID-19, Zika, Nipah virus, and hantavirus in that. We all need to take a step back and take a deep breath. Now, how are these agents delivered? They are spread through food, water, aircraft sprayers, vehicle sprayers, hand sprayers, by a mail containing a white powder, an envelope containing a white powder. Now they will have a human vector, animal vector. The air handling system may get infected. How do you suggest that a bioterrorism has occurred? Is that an epidemic curve that suggests a point source, what happened in Wuhan, or an extended source rather than a naturally propagated source? Identify a cluster of cases, high and rapid fatality among cases, large number of casualties occurring within the first 40 to 72 hours, and casualty distribution aligned with the wind direction, that is downstream. Things have occurred quite drastically rather than upstream. And illness type, which is highly unusual for a geographical area. Like I would say in Surat, there was a outbreak of plague. Increased number of sick or dead animals of varied species in a defined geographical area. Witness to an attack or discovery of appropriate delivery system is found, but then most of the time it is not found. a lower attack rate in people who were indoors than who were outdoors. Accepting situation where buildings ventilation system was used to disperse the agent. Now this is what I'm telling you is a very, very big possibility. Concluding for the biological agents is the vast number of biological agents are there. High index has to be there. Training awareness has to be done. Laboratory preparation has to be there, which the whole world was not prepared for it. And we need to have upgrade our laboratories to identify and to treat. Even after 2 years, we are just grappling with one after the other waves of COVID. Now coming to the last agents, they are radiological and nuclear agents. The nuclear agents are actually radiographic material generated from nuclear fission and fusion reaction. They are bombs. This is the nuclear bomb. Whereas radiological agents are radioactive material which is byproduced from mineral processing industry. Now this radioactive material has to be dispersed. Now this dispersion is carried out with a bomb. So both these agents involve a very obvious point source. Okay, the other two chemical and biological agents will not have a, you will not come to even realize, but this nuclear and radiological agents will come to realize that something gross has happened. Okay, now there are two elements, which is uranium and plutonium, which are actually part of nuclear bombs, from which nuclear bombs are made. And a nuclear weapon called an atomic bomb or nuclear warhead is an explosive device that derives its destructive force from a nuclear reaction, which is either fission or fusion. Okay, and then both of them are actually, they produce a huge amount of thermal energy as well as radiation, and the destruction is because a combination of both of them. Okay, so both these fission and fusion based bomb type release large quantity of energy from a very small amount of matter. They are really destructive. Now we know of only two nuclear bombs which were dropped. Little Boy was the name of the bomb which was dropped on Hiroshima on 6th August 1945, and Fat Man was dropped on 9th August at Nagasaki. Each one of them destroyed 5 square kilometers of cities each and caused death of over 140,000 persons in that year itself. Not talking about persons who died of cancer later on, and still the problems of the community with deformed children still being born. Very sad that the world has a huge stockpile of nuclear weapons. Leading is Russia, US, China. Pakistan has more than us. It is quite a solemn thing. In fact, a radiological weapon is something, like I said, is actually radioactivity. Now this radioactivity is spread with another bomb. This is lashed onto a bomb, and hence that bomb is called a dirty bomb, because the bomb explodes into an area and this radioactive material is spread there. Now this radioactive material causes the destruction. The bomb causes less destruction, the radioactive material causes more destruction. Then that is why it is called as dirty bomb. Now this requires a radiological dispersal device, and it can spread over a large area then. Effect on humans because of blast, thermal radiation, initial nuclear radiation, and the fallout of that. Okay, the genetic modification, the fallout of that. How do you manage it? Non-medical search and rescue, evacuation, detection of radiation, and dosimetry. Quarantine them, isolate them, triage them, site cleanup and reconstruct. Medical management is life-saving measures, decontamination, radioproduction and decorporation, and radioactive waste management. This is again very important thing. Site, person, and hospital all have to be done. I have finished my presentation. If there are any queries, you can always fall back to me at this email address. Thank you very much. Jai Hind.
Thank you, sir, for exploring a hidden aspect of silent killer. Thank you. Nice question. Can we go ahead with next patient?
Good evening, everybody. The topic for today's discussion is clinical productivity measurement in anesthesia. Working hard or hardly working? First of all, greetings from Gyan Sagar Medical College and Hospital, Patiala, Punjab, where I am presently working as a professor and head in the Department of Anesthesiology and Intensive Care. Coming back to the topic, what is meant by improving clinical productivity? First of all, it's a balance between the productivity drivers and productivity drains. That means the balance between the positives and the negatives. We have to boost the productivity drivers and we have to minimize the productivity drains. Then we have to determine how much capacity or potential exists within a specialty. Going by the present trends in our specialty, the trend productivity is helpful in workforce planning efforts. And we also have to develop physician compensation plans to improve the revenue. Productivity measurements have long been used to evaluate and compare physicians and physician practices because many practices use these data to develop incentives or performance-based compensation plans. Then the important question is why productivity should be measured. Why? In the private setting, measurements of individual work performed for the group is the basis of compensation, especially profit distribution. However, in academic anesthetic, the need to measure clinical productivity is demanded by medical school administrators and budgetary committees, who often may not understand the fundamental factors that determine the work output of anesthesiologists in comparison to other specialties. Now, what are the aims of productivity measurement? It is basically aimed to evaluate and compare physician and physician practices, to compare facilities, groups, and individuals, understanding the available measures and the variables that impact those measures, which can help group leaders to develop actionable measurement to improve anesthesia clinical productivity. Also, intergroup comparisons of clinical productivity are important for strategic planning and evaluation of clinical and business operations. For example, anesthesiologist group should consider surgical duration when making any strategic decision. Then why ability to measure productivity is important? Actually, it helps in individual compensation and in justification of budgets and staffing levels in our hospitals. Important question again, how to measure clinical productivity in anesthesiology? Basically, it is to analyze detailed clinical information such as drugs and agents used, equipment used in the particular surgical case. Also,
Clinical indicators and complication information should be collected for every patient. This data should be compared to current national patient safety goals, facility accreditation standards, and compliance initiatives to prepare a clinical productivity report. Now, each anesthesia provider should periodically complete competency reviews to ensure that his or her skills are up to date and contributing to meet productivity goals. It's a group practice. That means each anesthesiologist is going to test all the staff level, all the people working with him, whether subordinates or colleagues, and this will also help in the in-depth efficiency reports of everybody in the working in the operation theater. Now, productivity measurements may be based on per operating oversight, per operating room oversight, or per case measurements. That is TASA, Total American Society of Anesthesiologists per operation room. However, we are not accustomed to the ISA because private practitioner forum has been formulated, but there is no uniformity in the the total ISA per operating room thing have been worked out till now in India. Another part is billed per hour operating room per day or per hour per case or TASA per hour. And it also includes the type of facilities involved in that particular operation. So measuring productivity involves two components. It's an individual measurements and a group measurement. Previously, anesthesia groups would cover only one facility, but now they are part of large groups that cover multi-facilities, especially in the metro cities of India. So what are anesthesia groups basically? Most of the practitioners know this. An anesthesia department in one facility and sometimes in a smaller second facility. Local groups providing care is more than one large academic medical center. Sometimes the group covers two facilities, but shares staff on a daily basis as per demand. Then the facilities are considered as one facility because they combine the resources. The specialty teams or groups, what are they meaning for? If anesthesiologists at a facility are organized in distinct specialty teams providing care in distinct operating room sites and or with specific surgical services. This is a table which gives a comparison of the individual measurements and the group measurements about the clinical productivity in anesthesiology. Individual, it should reflect activities under the individual discretion and control, while in groups, it should be focused on how well the team of individuals are functioning and producing. The primary productivity metric used for anesthesiologists is TASA per clinical full-time equivalent. That is a ratio of the TASA over full-time equivalent. This was one of the studies published recently in 2019 about the measuring clinical productivity of anesthesiology groups. For anesthesiology groups, productivity must be done at the facility level in order to reduce some of the confounding factors. When industry or external comparisons are done, then the use of total ASI units per anesthetizing sites allow for overall productivity comparison. This is a flow chart of measuring the clinical productivity, the organizational factors, then the factors of concurrency, operation utilization or operation efficiency, ultimately leading to the TSA per full-time equivalent. How that is impact the which factors which impact the clinical productivity? It's a billable hour efficiency. TSA unit generated per billable hour indicate impact of base units and case lengths on TSA production. Base units reflect case complexity of pre-operative evaluation, case planning, and performance of the anesthetic procedure. Case length for a surgical procedure can vary by surgeon experience and skills and oblique site and is dependent upon surgeon, facility specific proficiency, and presence of trainees in that particular procedure. There are factors that determine the clinical productivity for anesthesia groups, like hourly productivity depending on surgical duration, type of surgery, and per operation room site. The organizational factors for academic anesthesiology departments are different. They're like the type of hospital, number of operating room, and types of surgical staff. And how is hourly clinical productivity measured? It is measured in total ASI units per hour of anesthesia care, that is ASA over per hour. I would have preferred using TISA per hour, provided they should be applicable in Indian culture very soon. Hoping we will be striving for it. In the time units and also days worked in a clinical setting. But there are certain factors that dilute TSA oblique FTE. That means the productivity decreases because of factors like prolonged turnovers and excessive gaps between cases, reduce TSA per work hour and TSA full-time equivalent. Geography of sites and total operating rooms running can limit optimal concurrency. Suppose concurrency is the number of operating room staff divided by the number of anesthesiologists available. Suppose the operation theater is in the remote area like villages or peripheries, and some are in the towns, and those are very busy, and the periphery is a very idle one. So definitely the productivity is going to get reduced there. Then efficient use of anesthesiology of personnel falls dramatically after prime time hours as efficient case management declines and the number of site falls below a level allowing optimal concurrency. This is known to everybody. Growing demands of non-operative room anesthesiologists contribute to issues in operational efficiency, and that is equal to low utilization rates and divergence in physician and scheduling efficiency. There are methods to measure individual clinical productivity like normalized clinical days per year, time units per operating room day work, normalized time units per year, total American Society of Anesthesiologists units per OR days, and normal total ASA units per year. This was a study which was published in 2002 comparing the clinical productivity of anesthesiologists in groups. The result of these studies were very important because it highlighted that 11 private practice and 9 academic groups from 12 states participated in the study. Productivity measurements that are influenced by duration of surgery differed significantly between groups, with private practice groups having shorter duration than academic groups. Although TSA over oversight measurements are similar in private practice and academic groups work significantly longer hours billed per oversight per day. Then how external comparisons of group productivity are done? It can be done by short surveys, which can result in industry data that would allow a group to answer social importance questions like, are we as productive as we should be? Or do we work longer hours than other group? And why do the anesthesiologists in one hospital produce more than any other hospital? Also, the use of total ASA units per anesthetizing sites allows for overall productivity comparison. Other productivity components like total ASA units per hour, hour per case, hour per operation room per day allow for leaders to develop productivity dashboards. This was one of the another studies published in 2000, abolishes method of various measures of individual productivity to define the methods best suited to academic anesthesiology, and the results were they were concluded. The authors determined that in their department, normalized clinical days per year is the most useful measure for individual productivity because it measures individual anesthesiologist's contribution to daily staffing. It includes all clinical sites and it is independent of non-anesthesia factors and is easy to collect and determine. Evaluation of clinical productivity and comparison of providers and facilities is uniquely challenging in anesthesiology because various factors outside the anesthesiologist's control can impact opportunity for revenue generation. And what are those challenges which help in quantifying individual productivity? Suppose in teaching hospitals, anesthesia is often administered in a team model and clinicians may be obliged to staff all clinical settings despite daily or weekly variations in the workload. The practice and billing of anesthesia services make it difficult to quantify individual productivity there. So challenges in measuring clinical productivity, there are more challenges like more complex approach for the anesthesiologist. For most non-anesthesiologists, productivity measures are based primarily on the source-based relative value scale units, usually called relative value units, and focus on work relative value units, which are determined from billed charges. However, anesthesia care is not billed using RBS, base procedure codes. Instead, It is built using ASA units and modifier units. So what is the problem with the ASA units? They may not accurately reflect the need of an anesthesiology department for anesthesiologists to perform required work. And there are some confounding factors which include that anesthesiologists' independent factors influence the number of ASA units charged per billing period. And also, total ASA units do not necessarily reflect increased reimbursement. However, not all clinical activities or a department are built using ASA units. That's very important. And staffing requirements of some clinical sites do not vary with the workload. Also, the problem with time units to assess individual clinical productivity include confining issues concurrently in the groups. It is also not clear whether days worked in a clinical setting can accurately measure the productivity of individual anesthesiologists. And RUVs impact only quantity rather than the quality of care. Ultimately, meaningful comparison between anesthesiology groups or individuals is difficult because of the broad and various difference in practice type and opportunities for TASA generation. Ultimately, if measurement of clinical productivity is so difficult and complicated, what is the answer to the question? Whether we should be working hard or we should be hardly working. So what is more important in measurements of clinical productivity? To increase productivity and efficiency, to improve fiscal viability through efforts aimed at decreasing cost of healthcare delivery, or just working hard, or we should say hardly working. Now, what is working hard basically means in our specialty? It is attending to emergency cases 24 hours into 7 days in a week, starting the lective OT list in time, waiting for long hours, working in OT if the last case is prolonged, when all the hospital staff is gone, and working without lunch break, working with old traditional equipment if no support for buying new equipment is there. Also, working with surgeons of different temperament efficiency, working in varied operation theaters, nursing homes, and hospitals with varied resource levels, and also working with least assistance most of the times, especially in the peripheries, lack of operation theater anesthesia assistance, and working on festival days like Diwali, especially for emergency cases. Now comes a very important part, hardly working. It looks like nobody's working here, but actually this includes the hardly noticeable smart administrative and supervisory work done by senior anesthesiology staff in the smooth running of the OT list. Research and clinical work in the OT involves both types of productivity, but it is the planning, administrative, and supervisory work that gives true shape and pace to the clinical productive work. Productivity in operation theater cannot be measured only in terms of economic gains. The endpoint of clinical productivity is ultimately academic growth and research publication along with the quality of the work done. The newer generation and newer equipment can improve clinical productivity, but seniors who supervise, guide, and protect juniors and trainees cannot be ignored at any cost. Ideal clinical productivity is the culmination of all hard work into a globally visible script, which is an end result of the balance between working hard and hardly working. So, what is more important, working hard or hardly working? The question, the answer can be given by everybody around here, but ultimately, the productivity drains in anesthesia have to be controlled, which actually leads to the decrease in clinical productivity. First of all, we should take care of the lack of teamwork. The teamwork is there, everything will be good. The poor communication skills to be taken care of. Important is ill health of anesthesiologist. Anesthesiologist can fall at any time. The negativity in the group should not be there. Sometimes we are working day and night, so don't enough sleep. You can suffer from burnout and stress. But at the end of the day, every case, important case, difficult case, you should have a writing and documenting on the paper. And continuous use of WhatsApp, Instagram, Facebook will make you fatigued. What are the measures which improve the productivity among anesthesiologists? First of all, improving physical and mental health of the anesthesiologist. There's a program of ISA Fit Anesthesiologist started by the ISA. That means only a fit anesthesiologist will be more important to make a patient fit for the surgery. And financial support should always be there. Then arming the operation theater and anesthesiologists with up-to-date equipment and tools, use of clinical decision support systems, use of electronic health records, perioperative softwares and apps. Anesthesiology staff should attend CMEs, webinars, so as to update their current knowledge. Then anesthesia technician and assistant should always be there, though they can be employed. So the conclusion is the ability to measure productivity has become an important issue facing anesthesiology departments in private practice and academic settings. Effort should be made to increase the clinical productivity. These are my references from where I have compiled this lecture. Thank you very much.
Thank you so much, sir. As an anesthesiologist, we work different from other clinicians. So thank you so much for throwing light on much needed aspect of anesthesiology.
Hello, I'm Dr. Sajesh. Good afternoon, everyone. And I request for organizers to play my recorded speech. Good afternoon, my dear friends. First of all, I thank the organizers to give me an opportunity to communicate with you, and I'm straight away going with my topic: reforming healthcare, cost-effective anesthesia. Yes. We are starting with the topic. Good afternoon. Reforming healthcare, the cost-effective anesthesia. Cost-effective strategies. Why? Why we should have cost-effective strategies? And who should do this? Who should perform these cost-effective strategies? And more than that, why be anesthesiologist? Why? 28% to 32% of the global disease burden comes from surgical diseases. With an aging population, the requirement of surgical procedures has been predicted to increase by 14% to 47%. So there is relevance for cost effectiveness or cost reduction in healthcare. Coming to insurance strategies in our country, in India, we have different insurance schemes, government subsidy schemes, Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, with its state extension schemes, social health insurance schemes like employee state insurance, CGHS, central government health schemes, and of course the private voluntary health insurance schemes that covers only 9% of the population. Around 11 crores of people are covered. Most of them are the affluent, high society or upper middle class people. Altogether, we have around 70% of the people have some kind of a coverage from government sector or from the private sector. And the rest 30% don't have any coverage from any individual health protection schemes. So we have they are paying out of their pocket, and in the government sector also, we know the quality of our government institutions. We in a developing country, we have limitations on the budget allocation on health. So we have our government institutions, healthcare institutions have limitations in high quality care for the low income group. Of course, the high affluent, high upper middle class society have a insurance coverage, private insurance coverage. They have an option to get good treatment in good centers. So anyway, the 70% have got some coverage, but the 30% predominantly they are paying out of their pocket. And Niti Aayog in this October 2021 as a study published this study, the recommendations also, the health insurance for the India's missing middle, that is the 30% of the low middle class group, they are absolutely, they don't have any insurance coverage. They are addressing on that aspect. We hope we will get good coverage for them also. So anyway, there is relevance for insurance cost reduction in our healthcare treatments. Whom should perform? So it's a teamwork. It's starting from the government, or from the government policies, the institutions, the head of the institutions, administrators, or various departments, surgical departments, medical department, nursing department, HR department. It's an interdepartmental coordinations. If that fails, this will be the outcome. So it's a whom should do? It's a teamwork. And last, why we anesthesiologists are concerned about the cost reduction. 30% of the income from ICU and OT are generated by anesthesiologists. So we have a great role in cost reduction or cost effectiveness. Role of anesthesiologist is it's a role of a captain of a ship. Coordination with administrators, surgeons, OT team members, and fellow anesthesiologists is key for the success. So here is in the perioperative period, the ICU, preoperative ICUs, and preoperative optimization in operation theatre, post-operative care units, and intensive care units, and outstation anesthesia, and in almost entire hospital he has got a reach there. He need his help is required in many of the places. So even though it's a captain, I'm sure that most of my friends has got an experience of a stewardship of a sailing ship, but that also an experience. Calm sea never made a good sailor. Hope that won't be there in your life furthermore. So coming to the strategies, as far as we anesthesiologists are concerned, the perioperative strategy, we are the perioperative physicians, so we have a perioperative strategy. So the preoperative, we can have a targeted pre-op assessment and patient-specific investigations, intraoperatively GA-wise, regional anesthesia, multimodal analgesia, ERAS, post-operative prevention of common complications, pain management, multimodal analgesia. We will take it one by one. Preoperative strategies, targeted pre-op assessment and patient-specific investigations. Preoperative testing, around 0 to 8.3% of the test results lead to management changes. Only on steady state, that's around 8.5% of the test results lead to management changes. The postoperative outcome were not associated with either testing or abnormal results in patients undergoing low-risk ambulatory surgeries. And also, the non-cardiac preoperative testing in non-cardiac elective surgery did not find convincing evidence that preoperative testing was beneficial in healthy adults undergoing non-cardiac surgery. And abnormal test results in comorbid patients were significantly and more frequently changing the anesthetic management compared to comorbid patients in some disease-specific tests. Altogether, testing should be based on the specific pathology, its comorbidity or disease-specific, and of course, according to the age. The interoperative strategies we already discussed, and cost-effective GA alterations. The use of low and minimal flow anesthesia has many advantages, including reduced volatile anesthetic agent consumption. And recent studies shown that the cost incurred for minimal flow anesthesia, that is fresh gas flow of 500 ml per minute using sevoflurane, was lower than low flow anesthesia, that is 1 liter per minute for 1 Mach hour of anesthesia. So coming to the minimal flow, that means the effective, the cost requirement of inhalation agent is reduced, and of course the cost will definitely reduce. Automated control of end-tidal sevoflurane with 500 ml per minute fresh gas flow was very cost effective when compared to conventional flow technique. Of course, quite obvious. A few words on the green OT. Is climate change is an issue? Anesthesia and role of OT? Is regional anesthesia is a solution? Let us consider. Climate change is a fact. We all know that. And no point in hiding out from that. Man is responsible for the climate change also. Whether you don't believe in global warming or not, it's there. And we are facing even now. In our Bay of Bengal, the inner Bay of Bengal, we have a raised temperature around from 26 to 27 or something. That means 1 to 1.5 degree rise in temperature is there, and that produces increased evaporation and high content, water content clouds, and low pressure waves, currents produced, and the effect is still we are facing in southern part of our country, Kerala, Karnataka, Tamil Nadu, Andhra, and all. Still we are having flood threats. So it's in real time we are facing it. Global warming potential, I'm not going to the details, but most of our sophisticated inhalation agents like sevoflurane and dexflurane have a high global warming potential. Or conventional general anesthesia technique, we need a sophisticated machines, and it's a polypharmacy there, multiple drugs are there, and of course as far as green OT is concerned, major concern is on inhalational agent. We are already discussed about the global warming potential of high global warming potential of higher end inhalation agents. Compared to general anesthesia, regional anesthesia, we need only a few drugs. And of course, the regional anesthesia techniques has revolutionized. Ultrasound has revolutionized the techniques, and it is very safe and very precise and very effective without much of side effects. And some of the studies in comparison of neuraxial block with general anesthesia on total hip replacement surgeries, it is neuraxial block is very effective. And complications of course, no technique is or no drug or no technique is devoid of complications. Complications of peripheral nerve blocks. We have serious complications of peripheral nerve blocks, including nerve injury, catheter infection, bleeding, and last local anesthetic systemic toxicity. But the intraneural injection occurs frequently with nerve stimulator or ultrasound guided technique. It is rarely associated with nerve injury. Of course, with an ultrasound in a trained ultrasound, hands of an ultrasound in a trained anesthesiologist, the injury produced is very minimal, and it is targeted, and we need only a low volume local anesthetic, so it's very effective, and we can get good blocks with the lower volumes. And lipid emulsion therapy is very effective in local anesthetic systemic toxicity. So not much worry about regional local anesthesia and nerve blocks, regional techniques, and that is of course better than general anesthesia as far as green OT is concerned, and of course our topic, the cost effectiveness. ultrasound guided nerve blocks. And another thing is segmental spinal anesthesia coming out in a big way, even in a remote settings or a minimal setup hospitals. It's very effective. It's becoming a big way. That's an entirely different topic, and I'm not going into the details of that. And if at all we are giving a general anesthesia, the take-home message is that use low flow anesthesia for the environmental protection point of view, and of course the cost effectiveness point of view. As far as possible, use a low flow anesthesia technique, and gas monitoring is possible. You can go with gas monitoring and minimal flow. At least use a low flow anesthesia. Another big topic coming out in a bigger way is opioid free anesthesia, OFA. We can avoid opioids. That produces a big change in the post-operative recovery and the patient comfort. And other side effects, of course, cost outs. TIVA, as far as possible, use a TIVA for a green OT point of view, and it's an environmental point of view, and of course, we can have a good TIVA combinations for faster recovery. Post-operative strategies, the prevention of common complications like post-operative nausea and vomiting, shivering that causes increased ICU stay or a post-operative stay that increases the cost, and another drugs we are using and the patient's discomfort, of course. The post-operative pain management, nerve blocks, catheters, whenever possible use a nerve block catheters, either epidural catheters or a nerve block catheters. It's very effective and gives a good patient satisfaction, provide good quality anesthesia and post-operative pain management. If not possible, at least use an adjuvants. We have a good adjuvants like clonidine, dexmedetomidine, and even if nothing is available, you can use dexamethasone for a prolonged post-operative analgesia. Of course, multimodal analgesia is the key. Opioid sparing analgesics, we have a plenty out there and a good option there. It's a big topic that is very useful for the ERAS. That's enhanced recovery after surgery. That's a fast tracking surgery is possible with these combined all these technique. That definitely that will reduce the cost of surgical procedures. Of course, the day care anesthesia, the most minimal cost effectiveness, maximum cost effectiveness with the day care anesthesia. We can have a minimal cost and patient stay and everything can be reduced. National Accreditation Board for Hospital and Healthcare Providers. It's a Board of Quality Council of India Associate. We're going to see it's an initiative, and most of the hospitals are having the national board accreditation. It's starting from 10-bedded hospital, up to 100-bedded hospital to 500 to 300-bedded hospital. They have a different plans and different accreditations. Altogether, it's a quality assurance body, but still it because of the quality assurance and the persistent training program, it is very useful for the cost effectiveness. Antimicrobial stewardship is sorry, one of the major programs, flagship program in the NABS, that is Sentinel or high-end antibiotics, is reduced or streamlined. Hospital infection control policies reduces and eventually stop the nosocomial infection in patient and staff. Device bundles also is very useful. ICU admission and discharge criteria, ICU admission made effective and readmission is misused. HR policies, the proper training of the staff is reduces error and that error producing damages and of course the escalation of the cost. Pre-exposure prophylaxis ensures staff safety. And quality monitors and quality indices, very, very important tool of NABH, helps to identify the areas where more interventions are required and where close monitoring is required, so that the resources can be channeled more effectively. Real-time corrective measures can be taken cost effectively. The immediate correction is one of the major advantage of the quality monitors and quality checks, and of course the audit and everything altogether is very cost effective. Purchase committees ensures that the equipment purchase is as per the need and spec and shall be determined more effectively. And another point is that we can purchase, it's a bulk purchasing, and we can avoid SOS or an emergency purchasing. That way we can avoid the escalation of cost. Budget, including the risk management, which ensures the risks within the hospital, both clinical and non-clinical, are identified prior and rectified timely. Quality, safety, and wellness are the motto of the NABH, but cost-effective quality, safety, and wellness is an art. We are not only the best perioperative physicians, but we are the best perioperative artists. New strategies has to be implemented in our routine anesthesia practice. Is the best cartoon you all know. One of these, our good friend Ganesh Chowdhury. The anesthesia apps, we have a various and plenty of anesthesia apps, starting from the regional anesthesia, TIFA, and academic activities. Different applications are there. It's very useful and very informative, and you can update your knowledge and skill through the apps. Of course, the smartphone is an integral part of our life, and we have to utilize the smartphone and mobile apps, and telemedicine is a very useful technique as that even if you are working in a remote place, you can consult with your friends or your seniors in a remote location, and you can communicate the real-time picture rather than telling the condition. You can show them what is exactly the patient is having, also the results or the monitor findings, all of the things we can show them, and we can take a good decision, good quality. We can assure, of course, the cost also is reduced. The social media, of course, social media is very useful and effective. We can utilize the social media platforms. We have WhatsApp groups and good Telegram groups, all other academic activities we have. Even now the Zoom also we are communicating with this. So, of course, if you have proper planning, your updated knowledge and everything, you can avoid this, and you can win the confidence of the patient. That is more important, the quality without affecting the cost effectiveness, without affecting the quality. Thank you, my dear friends. And even some of my friends, they are in different parts of the world. I'm using the social media platform before coming to this conference. We just talk and discuss about our friends, some of them abroad and in different parts of our country. We are discussing, and after the consulting them, thanks, my dear friends. Thank you, one and all. Have a bright anesthesia future. Hope you can maintain the quality of anesthesia, and of course the cost is a big problem in our country. Also, you should take all of your possible measures to reduce the cost. Have a bright future. Thank you, my dear friends.
Thank you so much, sir, for guiding and encouraging to be an artist. Welcome. Concluding this session, thank you so much all faculties for sharing their valuable knowledge and then guiding us. Thank you so much.
Thank you for giving an opportunity to speak in a national forum. And hi, Vandana. Okay.
Yeah, hi.
Hi.
Good to see everybody.
See you. It's nice to see you all. Okay, my Kapila, Narmada, and Vikas is military experience, excellent experience and all. Anyway, nice to meet you all. Thank you.
Yeah, thank you, IEC. Thank you very much, and was happy to hear all the excellent talks this afternoon.
Thank you, Mrinalini, for wonderful conference for series. Thank you. Shall we leave?
You can, sir.
Okay. So much.
you.